Ajit, you can proceed.
Yes, ma'am. Good evening. I, Dr. Ajit, welcome you all for this virtual CME on critical care updates organized by Indian Society of Anaesthesiologists, Nagpur City Branch, in association with NKPSIMS and Research Center and Lata Mangeshkar Hospital, Nagpur. Being an anesthetist, we all know how important is the critical care in our day-to-day practice, and in that COVID pandemic taught us importance of knowing the basics of mechanical ventilation, not only for anesthesia department but also for other various departments. And there is a tagline for sepsis: suspect sepsis saves life, indicating importance of sepsis control too. So I request Dr. Kiran Vevare ma'am, President ISA Nagpur City Branch, to say a few words.
Thank you, Ajit. Honorable Vice President of ISA National and Advisory Board Member MSCISA, Dr. Anjali Bure Madam, GC Member MSCISA and immediate past President Dr. Saurabh Burde, GC Member MSCISA Dr. Sheetal Dalal, esteemed faculties of today's CME Dr. Anant Rajput, Dr. Mohd Saif Khan, Chairpersons Dr. Imran, dignitaries who have joined online, Secretary Dr. Sarita, MOC Dr. Ajit, seniors, teachers, and my dear friends. Greetings from ISA Nagpur and a warm welcome to the CME on critical care updates. Mechanical ventilation is a complex and elusive topic, and we as anesthesiologists have to constantly deal with critically ill patients. Although we are managing our patients efficiently, we still need to constantly brush up our basics of ventilation and have a thorough understanding of the physiology and response to disease states. So let us understand the changes in compliance and resistance to pick up the ventilatory strategies from Dr. Anant Rajput. Sepsis is a life-threatening organ dysfunction which is caused by dysregulated host response to infection. It is a major healthcare problem affecting millions worldwide. Early identification and appropriate management in the initial hours after development of sepsis is very important for improved outcome. So let us listen to our esteemed speaker, Dr. Saif, about the recent updates in sepsis guidelines. I once again welcome you all and hand over to Dr. Ajit for further proceedings. Thank you.
Thank you, ma'am. Now I request Dr. Anjali Bure ma'am, Professor and HOD Department of Anesthesia, NKPSIMS and Research Center and Lata Mangeshkar Hospital and Vice President ISA National, to say a few words.
अजित अजून बुरे मॅडम अजून जॉईन नाही झालेले आहे.
नाही मी मॅडम
झाले हा
येस मॅडम
yes
yes ma'am. Welcome ma'am.
Yeah, thank you Ajit. Good evening all. Honorable President Dr. Kiran Vevare, GC members Maharashtra State Chapter ISA Dr. Saurabh Burde and Sheetal Dalal, Honorary Secretary Dr. Sarita Zograikar, other distinguished office bearers of ISA NCB, esteemed faculties, chairpersons, senior teachers, and dear members. Warm greetings from ISA National. I congratulate and I'm thankful to ISA NCB and Department of Anaesthesiology for organizing this webinar on critical care updates. I'm grateful to today's faculties and chairperson Dr. Anant Rajput, Director, Aureus Critical Care and Emergency, who's going to talk on basics of mechanical ventilation, topic close to everyone's heart. Dr. Mohd Saif Khan, Associate Professor, Department of Critical Care Medicine, Rajendra Institute of Medical Science, Ranchi. His deliberation is on recent updates on sepsis guidelines. Our own Dr. Imran is the Chairperson, Consultant Critical Care, Asian Care Center. Imran, we are so proud today that you are chairing this session, and it will be great to know the basics and current concepts from the stalwarts and experts. I once again congratulate the entire team and wish them success. Long live ISA. Thank you.
Thank you. Now I request our chairperson, Dr. Imran sir, who is consultant intensivist and anesthesiologist at Asian Critical Care Nagpur, to take this one forward. Imran sir.
Thank you, Dr. Ajit, for your wonderful opening. And at the outset, let me thank all my dear friends and respected seniors from ISNCB, President Ma'am, Dr. Kiran, Secretary Ma'am, Dr. Joglekar, Dr. Bhure, and all the team members for giving me opportunity to be here with you all. As everyone's think about the mechanical ventilation, this is again very close to our heart. Being anesthesiologist, we work day in and day out managing cases on mechanical ventilation, but we also need many a times reteaching, re-update, and it is a very good practice to keep ourselves updated. So the first talk is going to be delivered by Dr. Anant Rajput, who doesn't know any introduction. So may I request him to share his screen and we can start our session. Thank you.
Before that, I think he needs to introduce
Dr.
yes,
Anant,
Dr. Ajit.
Dr. Yeah, should I introduce him?
Yes, sir.
Go ahead.
Dr. Anant is a director of Aureus Critical Care and Emergency Nagpur. He's a consultant anesthesiologist and intensivist and pain management specialist. His area of interest is infection control, neuroanesthesia and neurocritical care, and interventional cancer pain management. His current scope of practice is a critical care management of all emergency cases, ARDS management, pneumonia, complicated post-operative cases, management of acute leukemic induction, oncoanesthesia, one lung anesthesia, all thoracic surgeries, pain management, both acute and chronic, including cancer pain. His past experience is from JNM Medical College, Savangi Varda. He did his MBBS, he did his post-graduation in MD Anesthesiology from KEM Nagpur, and he did his IDCC from Bridge Candy Hospital. He was associated with the Cancer Research Hospital Nagpur and SCG Cancer Hospital Nagpur, and presently he is a director and one of the consultant of Aureus Hospital Nagpur. So welcome, Dr. Anant. It would be very nice and exciting and thrilling to learn the good concept of mechanical ventilation from you. The kind of teaching I understand, I know how passionate you are about the teaching. So let's have a great session. Thank you so much.
Thank you, Imran. Thank you so much for the introduction. I think I'll just start sharing the screen because I may take a little longer time. So that's why I'll try to come to the point straight away so that we don't waste time and stick to the important points. Yes, as rightly said, the basics of mechanical ventilation are very, very important. What I'll be covering in this topic, the topic I prepared was because NKPSIMS was also involved. So I thought PG students and all these people will be involved. So from that point of view also, I tried to prepare, but I see a lot of senior faces, and I hope my presentation does not disappoint them. So request to all the seniors, and please bear with me. Dr. Bhure madam, Dr. Vivare madam, Dr. Joglekar madam, Ketki madam, and Dr. Ajit, please, thank you so much for the opportunity. I'll start with this. What I'm going to cover in this topic is why actually we need ventilator. Right? In this, I'll be covering what are the indications of ventilator, mechanical ventilation, and what is acute respiratory failure, what are the types, what are the reasons for hypoxemia, which will include shunt and VQ mismatch. How do ventilators work? What are the basic modes and principles to ventilate a patient? What are the contraindications, complications secondary to mechanical ventilation? So first is, why do we need a ventilator? So let's see a scenario where a cobra by victim is there, who has been given anti-snake venom already, but now starts feeling that he's breathless and is becoming drowsy. The ABG shows CO2 retention, so respiratory acidosis, and we can say that is in respiratory failure. So what do we do here? Because anti-venom has already been given, probably he's hemodynamically stable, but then his respiratory system is failing. So what do we do here? We want to push some air inside the lungs. What do we need to do? So we need to put some air in the lung. With the air, you get some oxygen, and in the process, the chest will expand. But the second part is very, very important. The air should also come out, and the chest should go back to its original position. That is very, very important. In the process, we will make the carbon dioxide come out. out. This concept is very important, that air goes in, it has to come out. So when we talk about ventilator is a machine which delivers the air. So it delivers inspiration basically, right? But expiration happens passively. So we have to always keep this in mind, that expiration is a process which is controlled by the patient's condition, not by the ventilator. Right? So you have to always observe. You can never say that I put this mode and the patient is not to be monitored. It cannot happen like this, right? Because only with ventilator you are controlling one half of the respiration and not the second half of the respiration, right? So for inspiration, what are my options? My options is to either put the patient in a negative pressure area with his head outside and create a negative atmosphere around his body. So that is called as negative pressure ventilation, or to put a tube in the throat and to push air inside the lungs. So these are two major different strategies of ventilation which were historically very important, because this was the first ventilator which was developed, that is negative pressure ventilation, and patients used to be inside. Now, technically, what was the problem in this? This is physiologically a good situation, but technically very difficult. It had some physiological challenges also. This was polio epidemic 1950, where negative pressure iron lungs were developed, negative pressure ventilators were developed. They thought it is physiology with which we are doing all this, but to care for such patient who is inside, whose whole body is inside an iron box, where we are fluctuating the pressures, is very difficult. So bed sore management, IV line management, and all this becomes very difficult. So they realized, let us try to find a simpler way in which they put a tube and try to push the air inside lung. But that is non-physiological method of ventilating a person, right? We all breathe with negative pressure. We generate negative intrathoracic pressure, and that is how we breathe. So changing the strategy from negative to positive pressure ventilation was important, because we could take care of the patient very well, but it poses a huge amount of physiological challenges for the patient that we'll be studying in the subsequent slides. So what in this situation I want to do? I want to give a tidal volume to this patient, say 500 ml with a respiratory rate of 20 breaths per minute with a I ratio of 1:2. So inspiratory time of 1 and expiratory time of 2. So now if 20 breaths per minute, so we divide 60 seconds by 20, we get one respiratory cycle of 30 seconds. Okay, 3 seconds. One respiratory cycle of 3 seconds. Now with I ratio of 1:2, is the pointer working for everyone? Yes. Okay, so if cycle with an I ratio of 1:2, we get an inspiratory time of 1 second practically. Only 1 second to deliver 500 ml. So let us multiply 500 ml with this, and what figure you get? You get a flow rate of 30 liters per minute during that 1 second we have to achieve. That is the entire idea why there is a difference between ICU ventilator and anesthesia ventilator. What do? We keep very low flow rates in anesthesia. We can keep less than 1 liter also very easily in low flow anesthesia and ventilate the patient, because we reuse the gases, right? But in ICU ventilators, we don't do that. So what you require is a very high flow in less time. This is just with respiratory rate of 20. If you go on increasing the respiratory rate, you go on changing the I ratios, your time for giving the tidal volume will go on reducing, and the flow demand may increase from 30 liters per minute to maybe 60 liters per minute. Right? To meet such a flow demand, you require a machine that works with higher pressure. So we are having this. This is a higher pressure. In anesthesia, what happens? We convert this to intermediate, then to low pressure system in our circuit. But here in ventilator, we do not do that. The low pressure system starts after the machine directly towards the patient. So we are supposed to deliver very high flow rates, and that can be only done by using high pressures. We'll be talking about it further in next few slides. So ICU ventilators, they work at higher pressure, and they require 60 psi, whether oxygen or air, whatever we are using, to work. And this pressure difference is required because you want to achieve that flow from this end of the machine to this, that is the patient's lungs, right? So it has to overcome the resistance from the tubings, ventilator tubings, the endotracheal tube, the airways of the patient, the lungs, the chest wall of the patient, all these resistance has to be overcome and the tidal volume has to be delivered, right? So that is the need why the ICU ventilators work on high pressure, right? Now, what are the indications of mechanical ventilation? Indications of mechanical ventilation, as simple, you want to deliver a breath, nothing more than that. Our machine can deliver one breath, right? That is the only purpose of ICU ventilator. So apnea will be the first most important indication, whether that is associated with hypercapnia or hypoxemia, that is the second or third indication, right? So apnea remains the first indication, and acute hypercapnia because of various other conditions in which we will not go in details, but acute hypoxemia and acute and chronic respiratory failure will remain as the basis. The other way to put up the indications, which I like, this is how I like to put up the indications, that is acute respiratory failure oblique apnea in ventilatory failure. Acute ventilatory failure, what you are seeing is failure of ventilation, right? So that can be treated very easily with ventilator. Second is very important from ICU point of view is impending ventilatory failure. Now you have to anticipate that this patient is going to end up in ventilatory failure. That's why in anticipation, I want to put the patient on ventilator. Right now the reports are looking fine, but this patient is not going to sustain a respiratory rate of 60 for another 1 hour, right? So in anticipation, we put the patient on mechanical ventilation. That is another very, very common indication for putting the patient on mechanical ventilation. Third is severe hypoxemia. Definitely, we all know about it after COVID that severe hypoxemia is one of the very important indications of mechanical ventilations. But another important category is prophylactic ventilation. So there is nothing wrong with the respiratory system. Lungs are okay, but because of some other medical conditions like a prolonged shock, a kind of surgery that patient has undergone, or some other indications which are unrelated to respiratory system, but you want the patient to be relaxed and paralyzed and be comfortable, so we put the patient on ventilator. So these are the 4 other categories or other way in which you can talk about indications of mechanical ventilation. What are the contraindications? Contraindications can be only very difficult to say that there is a contraindication to put a patient on mechanical ventilation. So contraindication can be untreated tension pneumothorax. The more you ventilate, more worsening of tension pneumothorax. So it takes hardly 30 seconds. Me and Imran have recently done something like that. Put a needle in tension pneumothorax, drain the tension pneumothorax, and put the patient on ventilator after that, right? So do the emergency management of tension pneumothorax, and then you go ahead with ventilation. So it is not an absolute contraindication. I would put it as a relative contraindication. Medical futility, yes, that is one possibility. We have a terminal ill cancer patient, or with somebody like end-stage renal disease, or with brain death situation. So medical futility is where we would avoid putting the patient on mechanical ventilation. I don't see many contraindications to put patient on ventilator. Yes, there can be a list of complications, commonly barotrauma or related lung injuries related to mechanical ventilation due to positive pressure ventilation, right? We'll discuss about it in separate slides. Accidental disconnection, fall in cardiac output is other problems which you are likely to face after the patient is put on the mechanical ventilation. So with this, we come to one topic, that is acute respiratory failure. What is acute respiratory failure? Although this is not part of this topic because we are talking about basics of mechanical ventilation, but definitely we have to have some understanding about it. I'll be touching this topic very briefly. That is inability of the respiratory system to maintain the oxygen delivery and carbon dioxide clearance from the tissues. Okay, with the given functional state of the tissue. Okay, so if the patient is in sepsis, right, so he may be able to do with some X amount of oxygen delivery with the tissues, but in sepsis, since the demand of oxygen and carbon dioxide production is higher, so in that state, the current respiratory system is inadequate for that patient, right? So that becomes an indication of putting the patient on mechanical ventilation. Very simply, when you want to classify acute respiratory failure, We have 4 types of acute respiratory failure. I don't want to go into that because what interests us is the oxygenation failure, that is fall in PaO2, usually less than 50 with whatever FiO2 you are delivering, even room air less than 50 is oxygenation failure. Ventilatory failure, PCO2 is suddenly rising more than 50 in acute scenario, not in chronic. Okay, not in chronic respiratory failure. Okay. So there are some things which you can achieve because of mechanical ventilation. So we should understand that basics here. So what we are seeing here, keep getting the oxygen in, right? You want to get the oxygen or the patient's oxygen is to be built up. Now that will depend on what physiological parameters. That is first parameter that will depend from ventilator point of view is P capital AO2, that is pressure of oxygen in the alveolus. Okay, it is pressure of oxygen, partial pressure of oxygen in the alveolus. Now indirectly this will depend on FiO2, what FiO2 will be giving to the patient. What is the carbon dioxide which is coming within the alveolus from the patient's body? What are the alveolar pressure, overall alveolar pressure, whether it is 760 or more than that. With some ventilator strategies, you can push the alveolar pressure higher, like applying PEEP. Okay, so what happens by applying PEEP? You push the alveolar pressure towards higher. The mean alveolar pressure is increased, and thereby you increase the partial pressure of oxygen in the alveolus. And obviously, if the alveolus is not going to be ventilated for a very longer period of time, gradually carbon dioxide will enter the alveolus and gradually the P capital AO2 will reduce. So ventilating the alveolus is also very important. So P capital AO2 depends on these 4 parameters. Besides this, oxygenation also depends on diffusing capacity of the lungs and match not only the alveolar basement membrane condition, alveolar basement membrane condition. It does not depend only on that, but it depends on the perfusion of the lung. So what is the hemodynamic status of the patient? If the patient is severely hypotensive, you will find that patient can desaturate, right? So matching of this ventilation with this perfusion. So VQ mismatch or matching is very important for oxygenation, right? So these are the parameters which will be very important, physiological parameters which will be very important for maintaining the oxygenation of a patient on ventilator. Now, how do you get the carbon dioxide out from a patient's of ventilator? By increasing the respiratory rate, by increasing the tidal volume, in all by manipulating the minute ventilation. Okay, so that is how you bring the carbon dioxide out. So oxygen parameters are different from carbon dioxide parameters on the ventilator. But another important concept is there, that is the dead space. Dead space is, we usually talk in terms of ventilator. When we talk about dead space, we talk about VD-VT ratio. What is VD-VT ratio? It's a dead space upon the tidal volume. So dead space is not an absolute figure, right? And dead space can also be anatomical dead space or physiological dead space. Anatomical dead space can be because of the various tubings connected to the patient's inherent dead space in the trachea, bronchi, and all respiratory passages, or physiological dead space. We'll be talking about physiological dead space in coming few slides, right? So what are the main determinants from point of view of oxygenation? So if you have a patient on ventilator who is desaturating, what you will do? You will try to increase the FiO2. You will try to increase the mean alveolar pressure. You will try to properly ventilate the patient, right? So all this can be easily done by adding PEEP, right? You can increase the PEEP. We'll further come to this slide when we end the session, right? So how to increase the oxygen? And when you want to remove the carbon dioxide from the patient on ventilator, so you have to increase the minute ventilation. How do we increase the minute ventilation? Increase the respiratory rate, increase the tidal volume, right? So these are the strategies, basics about getting the oxygen in and removing the carbon dioxide. Now coming to another very important concept, it is shunting. So I will not go in this classification of shunt, but I would like to discuss this part, that is zoning of lung. So lung is divided into 3 zones from point of view of ventilation, perfusion, matching. In this, very important concept is the pressure in the alveolus. Now you can see in zone 1, this is alveolus, right? The pressure in the alveolus is more than the arterial pressure. So you will see in zone 1, the blood cannot flow very easily through the alveolus, right? And it is more than venous pressure. So this kind of circulation is not very good. So this becomes zone 1. Zone 1. What is happening in zone 1? Zone 1 is nicely getting ventilated, but not with perfusion. Okay, so this is a wasteful ventilation. I would call it wasteful ventilation. Ventilation without getting the blood oxygenated. So that is called as dead space ventilation, right? Wasteful ventilation or dead space ventilation. Ventilation without any perfusion. In zone 2 is the most optimum zone where the arterial pressure is more than the alveolar pressure and which is more than the venous pressure. So what happens? The blood is easily flowing across like this and getting oxygenated. This is also getting ventilated. Whereas what is happening in zone 3? The zone 3 is lower zone of lung, either posteriorly when the patient is lying supine or in the propped up position when the abdominal distension is taking place, the lower zone atlectatic part of lung. That is zone 3. What happens in zone 3? The arterial pressure is more than the venous pressure and both the pressures are more than the alveolar pressure because alveolus is not getting properly ventilated in zone 3. So deoxygenated blood from the right side of the heart reaches without oxygenation to the left side of the heart, right? So zone 2 is the most optimum zone. Zone 1 is where the dead space ventilation is taking place and zone 3 is where we have a shunt, right? So what is shunt? Shunt is without oxygenation, the blood from the right side is reaching the left side. So that is zone 3. Coming to this same concept here, I am trying to explain in this form here. This is the optimum condition where the alveolus is getting ventilated, blood from the right side of the heart is reaching left side with oxygenation. In this diagram, the second diagram, central diagram, the alveolus is getting ventilated, but from the right side is not reaching the left side. What are the clinical conditions? Let's try to see that. What are the clinical conditions in which this can happen where ventilation of the lung is good? Is it hypotension, pulmonary embolism, where the blood from the right side will not go towards left side? So this will become dead space ventilation and where there will be a problem to the patient. The second is if there is no ventilation, right, but the blood is flowing. So this becomes a shunt situation or also called as VQ mismatch. These are all types of VQ mismatch. Okay. If this part is clear, can I move on? Okay, so we come to next important physiological part, that is compliance curve of lung. Why am I trying to discuss? We all have studied this in details, but it is closely associated with the ventilator graphics. That's why I'm trying to. We want to ventilate the patient in this portion of the lung, that is the slope of the curve. Okay, we don't want to ventilate a patient here, right? So we don't want to use that pressure which gives us this kind of volume, right? We want to ventilate patient here, or neither we want the patient to be going in the upper part. So here there will be a risk of barotrauma. Here there will be a risk of atelectotrauma. Atelectotrauma is when the lung is collapsing completely and reopening, collapsing, reopening. This is called as atelectotrauma. This happens because when we are not properly ventilating or not keeping the airways open in the lung. We will be discussing about it again in subsequent slide. Now let's try to correlate this graph with this graph. This graph we are all familiar. So this is a pressure time curve. Pressure time curve in a volume control mode. Okay, volume control mode. Now what is happening? This is A, point A is PEEP, right? Now from point A, as soon as we start ventilating the patient, the pressure inside the patient increases and it reaches to point B. Now, what is the difference between point A and point B? Why this is happening? This is the zone of resistance, airway resistance. Okay, the gas from the ventilator goes inside the patient but is not reaching the alveolus. Alveolus is the place where the lung is having compliance, not the airway. Right now, if we talk about the anatomy and physiology of the lung, so what we see is lung is from trachea, it is divided into two main bronchus to lower bronchus, lower to subsequent bronchopulmonary segments and subsequently onwards. So then we put the generation of bronchus. So trachea becomes first generation, bronchus becomes second generation, then lower bronchus third generation. Like that, generations are there. Almost 27 to 29 generations are there. up to alveolus, right? From 23 generations, 23 onwards, there are respiratory bronchioles. Okay, what are respiratory bronchioles? They are the passages of the alveolus which do not have linings. Okay, now what is bronchus and what is alveolus? Bronchus has thick wall surrounded by muscular layer, right? And alveolus does not have a muscular layer, right? So there are no muscles. So what is the seat of resistance in the airway? It is the terminal bronchiole. So it will be somewhere close to up to generation 21 to 23, up to where there will be terminal bronchioles. There onward, after that, there are only respiratory bronchioles. In respiratory bronchioles, gas exchange can take place, right? And they do not have muscle layer. So they are liable to collapse, right? They will collapse and they will not allow the air to pass beyond them up to the alveolus. Now, how can you open this? By putting some pressure. So when you apply this initial pressure from point A to point B, these respiratory bronchioles start opening. And after this, the alveolus starts getting ventilated. So the curve, instead of remaining steep upwards, it slopes. It becomes a slope, right? This is a phase where the alveolus is getting ventilated up to point C. Okay, up to point C, the alveolus is getting ventilated in a volume control mode. Now, after that, what has happened? There is a pause in the ventilation. Okay, so inspiration is also stopped, expiration is also stopped, and everything is paused. So there is drop in the pressure, but since expiration is also not taking place, so the air gets redistributed inside the lung during the pause time from D to E, and then from E the expiration starts. So you can see here, this is inspiratory phase, this is expiratory phase. I have tried to explain the different positions, why this shape of curve is coming in a volume control mode, right? And please now try to correlate with this curve. This point B comes practically here, right? Where the pressure rises initially, but there is no change in volume, right? Then there is sudden change in volume along with the change in pressure. So unit change in pressure and unit change in volume is taking place from B to C. This portion of curve you can say is, sorry, should I continue?
Yes, please continue. I'll
Okay.
mute.
Okay, ma'am. So this point can correspond to point C. Okay, so you are supposed to ventilate the patient in this zone of curve, right? And I hope I've tried to explain this graph. There are some lines in this graph. This horizontal line indicates the presence of PEEP. We can see here, the PEEP has been labeled. This vertical green line that you can see indicates the active inspiration, where the flow is taking place, right, from ventilator to the patient. Okay, so green line divides in that phase. And after this green line, whatever is happening, it is because of the redistribution. There is no flow from ventilator to the patient, but redistribution of the gases within the lung. And then from this point, expiration has begun. Okay, so we'll be seeing all these graphs again and again many times in subsequent slides. Okay, so we come to this graph, what we are seeing, the same curve we are seeing here. So with this curve, we realize that there is a peak pressure, there is a plateau pressure, okay, and there is a mean airway pressure. So what is peak pressure? That is the highest pressure during the respiratory cycle. Obviously, in a positive pressure ventilation situation, it will be during the inspiration only, right? Now, this graph indicates the correlation between pressure and flow. As you can see, the flow has started here, then the flow plateaus and the flow stops, comes to zero. There is no flow in this light blue zone, which corresponds to the plateau here. Okay, so no flow zone. This is pause pressure. On ventilator, this is called as pause pressure. Okay, so peak pressure, pause pressure. We have to understand that volume is being delivered. This is volume against time curve. So volume is being delivered, then the volume is being held at the same position, and then the expiration or the volume starts reducing inside the lung. So this is a volume against time curve, this is flow against time curve, and this is pressure against time curve. Right? So what is peak airway pressure? It is the highest pressure during the respiratory cycle. What is plateau pressure? During the pause, whatever pressure you achieve is plateau pressure. Okay, what is mean pressure? Overall, including inspiration as well as expiration, what is the mean pressure in the airway throughout the respiratory cycle? That will be called as mean airway pressure. It is not a real pressure, it is a calculated pressure. Okay, that pressure is actually there inside the alveolus. So now what we are doing to the alveolus, we are doing something like this, right? We are not doing like this. We don't want this to happen to alveolus, right? This is atelectasis opening. Atelectasis opening. We don't want this to happen. What we want to happen? Something like this. So mean airway pressure throughout the respiratory cycle, there has to be some positive. It is just like mean airway pressure is just like apna mean arterial pressure. Okay, so there's a systolic pressure, there's a diastolic pressure, and mean arterial pressure. So we have a peak pressure, plateau pressure, and then we have mean airway pressure, right? So mean airway pressure is the one which determines oxygenation. If you remember, now this slide which I was talking about, so I was talking about alveolar pressure here, right? How the oxygenation is. So that is the mean air pressure, airway pressure. Okay. Now with this background, we come to the lung compliance. So from ventilator point of view, we have got two conditions, that is dynamic compliance and static compliance. Okay. Again, coming back to this curve, we can see that air is flowing, or the flow phase is only up to here, whereas in pause there is no flow, right? So this becomes static area, this becomes dynamic area, right? So obviously this pressure will play a role in dynamic compliance, and this pressure will play a role in static compliance. What is lung compliance? It is change in lung volume due to change in pressure. Unit change in lung volume due to unit change in pressure. So if I increase the pressure by 1 centimeter of water, what is the amount of volume change taking place inside the lung? It indirectly tells us about the stretchability of the lung when we talk about positive pressure ventilation. Okay, in normal person, we do it with a negative pressure ventilation. Okay, but in positive pressure ventilation, we increase the pressure, whereas in negative pressure ventilation, we decrease the pressure. But the lung stretchability remains almost similar, right? So delta V upon delta P, that is change in volume upon change in pressure. So then we have got two types of compliance. One is static compliance and one is dynamic compliance. Now dynamic compliance, since there is flow of air taking place, so obviously the resistance will contribute through the passage, right? So airway resistance, dynamic compliance talks about the airway resistance. It talks about the elastic property of lung as well as chest wall. Whereas static compliance, since there is no flow, absolutely flow has stopped, only the recoil of the lung and chest wall will be counted here. Okay, so airway resistance is minus. So difference between static and dynamic compliance is going to practically talk about the airway resistance. Okay, so coming to the formula, static compliance, tidal volume. Okay, so as we said, the compliance is volume upon pressure. Okay, so for static compliance, tidal volume, plateau pressure here, because static situation is there, plateau pressure minus P. Whereas for dynamic compliance, it is tidal volume, peak airway pressure minus P. Okay, am I okay with the compliance part till now? Okay, I'll try to hurry up here on. Yeah, I'll talk about a little bit about work of breathing. The basic use of ventilator is to take away the work of breathing, right? So to relax the muscles of respiration, to improve the physiology of the patient, and then load the muscles with the work of breathing. So what does actually ventilator do? It takes away the work of breathing of the patient, thereby reduces the stress. The work of breathing can be taken as a company which makes profit or loss, right? So what is the purpose of respiration? You take in oxygen and put out carbon dioxide. The oxygen which is taken in should produce X amount of energy, right? If you are requiring more efforts to get X amount of energy, so your effort requirement is X plus 10. So you are going to be a loss-making company. So with X plus 10, you are producing energy of X only, right? So work of breathing is a very important concept as far as mechanical ventilation is concerned. You should always keep it in mind when you are weaning this patient. This is a common mistake which anesthetists do on table. They try to extubate a septic patient, a perforation patient on table, feeling that I have done very. You have to understand that his demand, body demand for minute ventilation is very high, which he is probably not going to make because he's been septic with septic myopathy or all this, which he's not going to be able to sustain. So instead of trying to extubate, you should put this patient on ventilator. So something like that we have to think while working on ventilator. So if the work of breathing has gone down, then only we try to extubate this patient or wean the patient from ventilators. So what are the factors which affect the work of breathing? The FRC, compliance of the lung, the chest wall condition, the airway resistance, all should be in our favorable side to say that work of breathing has gone down and the patient can be weaned. Okay. Now coming to some parameters which we'll be talking about in ventilator. As I said, ventilator is a machine which talks only about inspiration, not about expiration. We don't actually affect the expiration. Expiration is done by the patient himself, right? Whatever we play is with inspiration. So inspiratory time, setting of the inspiratory time on ventilator is very important. It is either set as the percentage of the respiratory cycle or as I ratio. So once you set a respiratory rate, let us go back to first example that we had taken. It was respiratory rate of 20, okay, per minute. So we get a respiratory cycle time of 3. So every 3 seconds, okay, you will get inspiration and expiration. Okay, so 1:2 if you set after the respiratory rate, so automatically you have decided the inspiratory time to be of 1 second. Okay, so either you set I ratio with respiratory rate, or it is set as the percentage of the respiratory cycle. Okay, whatever is the respiratory rate, I want inspiratory time to be 25% of the respiratory cycle, or 33% of the respiratory cycle, or 50%. If you say 50% of the respiratory cycle, it means I ratio is 1:1, right? So expiratory time, as I am repeatedly saying, is not done by the ventilator. It is the leftover time which you leave after setting the inspiratory time, right? Inspiratory time is for improving the oxygenation. If you have a longer inspiratory time, you will have better distribution of gases inside the lung, within the lung, and your hypoxia correction will be better. The longer inspiratory time gives you lesser pressures because the flow rate reduces. Okay, Poiseuille's law, if we talk about Poiseuille's law, is what it talks about the flow rate and viscosity and the airway resistance and everything put together, the flow of gases, right? So in that, if you understand, if you are saying that I'm increasing the time for the flow rate goes down, so the pressure required to generate the same kind of respiration goes down, right? So by reducing the inspiratory time, you increase the pressures required to the to ventilate the patient, and thereby you increase the chance of barotrauma or trauma due to pressure, right? But at the same time, if you compromise the expiratory time by increasing too much of inspiratory time, you increase the risk of gas trapping. What is gas trapping? We'll talk about gas trapping in further few slides, right? Coming to another important thing, that is PEEP. What is PEEP? PEEP is positive end expiratory pressure. What is the purpose of PEEP? We discussed that it increases the mean alveolar pressure, thereby it improves the oxygenation, or it can also cause recruitment of the collapsed alveolus. So what we are doing, not allowing the patient to expire completely, right? COPD patients doing pursed-lip respiration. What they're doing, they're building up pressure inside. So what they do with the alveolus inflates, but it does not collapse. So what does PEEP do? It allows the alveolus to move something like this, or instead of moving like this. Okay, so that is the point of using PEEP. This is by recruitment, by using the collapsed alveolus, it reduces the PEEP, reduces the shunting, and thereby improves the oxygenation, right? Now coming to gas trapping, we just spoke about this gas trapping business. We all know that expiration is a passive process. It is not governed. There is no method by which the ventilator sucks out the air which has gone inside. And expiration determines the carbon dioxide levels, right? So in asthma COPD patients, what happens? The airway narrowing is there. So more time is required for the same amount of gas to come out. So expiratory time has to be longer. If there is inadequate expiratory time, so if I am a COPD patient and I start breathing like this, so what happens? I am not giving adequate time for expiration and I am taking a next breath. So same thing you do on ventilator for COPD patient. What happens? The gas starts accumulating inside the alveolus and the alveolus starts stretching itself and ultimately it can rupture. The balloon can burst, right? So this will be called as barotrauma or hyper-progressive hyperinflation of the alveoli. It will not always result in rupture. There can be other things which can happen, that the blood flow through the alveolus, right? It will surpass the level, the pressure inside the alveolus will surpass the pulmonary arterial pressure. So perfusion of the alveolus will also be impaired. So flow of blood from the right side of the heart to left side will not take place. So this all side effects can take place and the patient may land up in an arrest. So what is, suppose a patient of asthma, you intubated and you put on ventilator and he's arrested. So what you will try to do, you will try to look into whether there is a pneumothorax. If there is no pneumothorax, then disconnect the patient, press on the chest, allow the air to come out. The air trapped inside the chest should come out and then reconnect the patient to ventilator and try to ventilate again. The second time, reduce the respiratory rate. Although we wanted for carbon dioxide to come out, we have increased the respiratory rate. But here, reduce the respiratory rate, give more time for expiration, right? So this is the strategy that we need to do for gas trapping. Now, gas trapping leads to intrinsic PEEP. Intrinsic PEEP, so PEEP, we just spoke about PEEP is positive end expiratory pressure, which is normally there inside the normal person, also because of the respiratory bronchioles. They collapse and they maintain the PEEP inside the alveolus so that alveolus does not collapse completely, right? So we have an intrinsic PEEP. This intrinsic PEEP can increase in COPD or asthmatic patients or patients in which there is bronchoconstriction, right? How to measure this intrinsic PEEP? You put the patient on volume control mode and during the expiration, you hold the expiration of the patient. There is a button for expiratory hold on ventilator. You hold this button. What you will see, the PEEP you have set, suppose you have set a PEEP of 5, right? So this pressure will drop to the PEEP of 5, but after certain time, this pressure will increase, okay? More than 5. So you are not applied that much PEEP, but the pressure is going up. That means there is some intrinsic PEEP. And this total PEEP, this is called as PEEP total, okay? Or written as PEEP tot, okay? PEEP total here. How do you get the intrinsic PEEP? From PEEP total, you minus the applied, that is extrinsic PEEP, okay? E is extrinsic PEEP, that the PEEP you have applied from the ventilator, and you get the intrinsic PEEP. What is the idea? Why we want to see the intrinsic PEEP? While setting ventilators for such patients, what you need to do, you try to go towards the extrinsic, or sorry, PEEP total. So you push up the PEEP, external PEEP, towards the PEEP total, so that the alveolus, the terminal airways are kept open during the expiration, right? Okay, and allowing expiration to take place, right? So that is the idea of finding out PEEP, intrinsic PEEP, right? That happens in asthma and COPD patients, which leads to gas trapping and cardiovascular compromise and barotrauma, which I spoke about. What are the physiological effects of putting a patient on positive pressure ventilation? There are respiratory effects which can happen. There are cardiac effects. There are hemodynamic effects, renal, neurologic, hepatic, intra-abdominal, which will just spend 5 minutes on all this. The cardiac effects, what happens because of the positive pressure ventilation? The venous return to the chest or the right side of the heart will be impaired, and thereby you will have hypotension, okay? For the LV, okay, for the left ventricle. Now this is very important situation. We are seeing that T indicates tension. This is, I think, Laplace law. Laplace law applies to spherical objects, right? So Laplace law, the tension on the wall, okay, is proportionate to the transmural pressure across the wall and it's proportional to the radius of the wall and divided by the h is the thickness of the wall. Okay, height of the myometrium. Okay, myocardium, sorry, not myometrium, myocardium. Okay, so when you change the transpleural pressure, okay, this transpleural pressure, so pressure outside, so we have lungs on both the sides, the heart is in center, right? Now with the negative pressure, what is happening? The LV is contracting, and with the negative pressure, it is being pulled outside, so it requires more force to contract. This is a spontaneously breathing patient. Whereas in positive pressure ventilation, what will happen? When the LV is contracting and you are delivering the breath, the LV will be assisted, right? Right? So what are the cardiac effects? The LV is assisted by the positive pressure ventilation. Okay? The theory I tried to explain with this equation also. So what are the overall cardiac effects that we see when we put a patient on ventilator? There will be overall reduction in the cardiac output because of the decrease in the venous return when you put a patient on positive pressure ventilation. But in a failing heart, failing LV, when a patient has failing LV, that patient will be benefited, the cardiac output will be improved in those patients. So in normal contractility, cardiac output goes down. In decreased contractility, cardiac output improves. Right? Overall, what will happen? How do you see the CVP or pulmonary artery pressure during ventilation? There is no correlation. Please do not try to say that I have applied PEEP of 5, so my CVP will increase by 5. No, there is no correlation between the two. It depends on so many other things besides just the PEEP, right? So lung compliance, chest wall condition, the transfer of pressure across the pericardium, all this will determine the conversion of PEEP to CVP. You should not do that. Right? And hemodynamically, you will find most of the time, as soon as you put the patient on ventilator, there will be hypotension. There are several reasons because for the hypotension, but you should be prepared to handle. That is the message that I want to give. Handle the hypotension after putting the patient on ventilator. Left side versus right side heart. The afterload of right heart is increase, thereby the load on the heart is increased by putting the patient on ventilator, whereas left heart is assisted. Okay. This is again the same diagram during ventilation. What you are seeing, this is alveolus, this is right side of the heart, this is left side of the heart. The pressure here has increased, so it will be pressing on the right side of the heart, whereas it will be assisting the left side of the heart. So always remember to tackle the hypotension after intubation and ventilation, right? Respiratory system. Now what happens from negative pressure, you have converted to positive pressure. So alveolus are getting stretched, right? So there is a shear injury, stress injury to the alveolus because of positive pressure. There will be a shift of alveolar fluid. So there's somebody who's having pulmonary edema, you push the patient on the positive pressure ventilation, the fluid will be shifted because the mean alveolar pressure is increased. So the fluid will be shifted from the alveolus into the pulmonary capillaries. So there will be compression of the pulmonary capillaries. So pulmonary hypertension will worsen with positive pressure ventilation. So there can be chances of barotrauma, respiratory tract changes. We know that after 4 hours of intubation, the mucociliary clearance, movement, and everything changes. So that puts the patient at risk of VAP after putting the patient on. Then there can be biotrauma, right? So if I have my skin which is rubbing against something continuously, something like this, so there is an inflammation which can take place, right? So same thing is happening inside the alveolus. The air is rubbing, instead of negative pressure, it is positive pressure. So air is rustling inside and injuring the alveolus all the time. So a biotrauma takes place and chemical mediators are released, and which can contribute to the lung injury. So this kind of respiratory changes and cardiac changes, hemodynamic changes. If the cardiac output reduces, then renal output, renal perfusion will be impaired. Neurologically, venous drainage of the brain is affected. Hepatically, the positive pressure ventilation, hepatic veins drain directly into IVC, and thereby there is congestion of the liver, so hepatic circulation is impaired, intra-abdominal pressure is increased, the work of breathing, all this is affected. Now let's come to the ventilator, because we're running a little short of time. I'll just now try to come to ventilator proper, right? So let's come to commonly used terms for ventilator. So when the ventilators are driven by power, right? They are driven by power. The power can be pneumatic and electric. All of us know about bird ventilator, at least the seniors, they know about bird ventilator, right? So, or Manley was used in anesthesia very frequently. So that is not driven by electricity, right? It is driven by the pressure of the gas. So it has a bellow, and from above the bellow is pressed by another gas, and that's how it works. Or because of some mechanical way, the pneumatic ventilators work without electricity, right? But there, most of the ventilators now, what we are getting is working with both mechanisms, electric as well as pneumatic. Then drive mechanism, there can be bellows, pistons. We know that I think piston was used in Drager anesthesia machine, right? But nowadays in our ventilators, we have microprocessors and valves, right? Valves which are controlled by microprocessors, and that is how we try to deliver. Now, with this idea, we come to something called a servo feedback mechanism. Now, what is servo feedback mechanism? It's a closed loop communication between the ventilator and whatever happening to the patient because of ventilator. So ventilator is constantly looking into the pressures, the flows, it is delivering the oxygen concentration, everything feedback is going back to the ventilator. This is shown in this diagram. Sorry for this. This I have prepared myself. So the ventilator is like a CPU, right? And ventilator, actually the ventilator part, mechanical part of ventilation is this. This is the area in which there is mixture of gases, right? We are supplying oxygen and air. Both are controlled by valves. These valves are controlled by the CPU. Okay? So the valves, you decide FiO2, depending on that, the valves open and allow. There are various valves. This is a fluidic valve. This is solenoid valve. So various types of valves are used to control the flow from high pressure. Generally high pressure, we use fluidic valves, right? So fluidic valves are up there, which ultimately mix the gases in certain area. From there, the oxygen sensor is there, which again feeds to this. So suppose I have set a FiO2 of 60%. And after getting this air and oxygen mixture, the FiO2 is reaching only up to 50%. So immediately computer what will do? It will increase the flow from oxygen side and bring the FiO2 to normal. This is called as servo feedback mechanism, right? So it manipulates itself to the whatever settings we have made, right? That smart ventilators now are coming in the market, right? So whatever we are using, they are basically computers. Then this is outflow. After this is outflow. So this is the inspiratory limb of the patient, and the blue one is the expiratory limb of the patient. What here there is again a valve which controls the inspiratory limb, and there is a valve which controls the expiratory limb. So what I have shown here is the inspiratory limb is open and the patient gas is flowing from here to here, whereas the expiratory limb is closed. So the gas will not return back to the ventilator, it will go to the patient itself. So this is our inspiratory phase that we are seeing. At the same time, these two valves, besides these two valves, there are flow sensors. The green color ones are flow sensors in both inspiratory as well as expiratory. Then there is a pressure sensor, okay? Pressure sensor in the expiratory side of the ventilator. All these are continuously feeding the responses to the ventilator, and continuously ventilator is assessing all this and manipulating itself to give whatever modes and other things we are doing. There can be additional proximal airway pressure sensor which can we add. So there are some tubes in which you will see at the Y piece of the ventilator, there is an additional port where you can connect the tubing back to the ventilator. So that is a PAW written there. So that is proximal airway pressure. It is more accurate than the pressure sensed by the ventilator from the expiratory limb, right? Now we come to the control system or modes, right? So what is mode? Mode is basically some variable which will around which the entire mode is designed, right? So that variable will be called as that controller, right? Controller is a primary variable providing a mode of ventilation within a specific parameter. So there are four basic things. So either there can be a pressure control system, a volume control system, a flow control system, or time control. So there are four things in ventilator. We have to, whenever we talk about ventilator, we have to understand that there are four controllers: pressure, volume, flow, and time, right? So this will control the entire mode of the ventilator, right? And when we say pressure control mode, that means Around the pressure, all other variables are working, and the mode becomes pressure control. If we say volume control mode, around the volume, we set the volume, and around that, that does not mean that pressure is not playing any role in volume control mode, right? It should not be taken that way, right? All the 4 variables are going to be there in all the modes at all the time, right? Besides this, without these variables, you cannot have ventilation. So after that, I come to other terms. What is trigger? Right? Trigger is initiation of inspiration. What tells the ventilator that now the inspiration has to begin? It can be time, like I tell the ventilator that, okay, give 20 breaths per minute. That means 60 seconds divided by 3. So every third second, 3 seconds, you have to give 1 breath. That is what ventilator understands. Okay, so that becomes time triggering. Okay, if the patient is triggering, so there can be pressure triggering, flow triggering. Okay, so drop in the pressure of the system, the patient is breathing, ventilator gives the breath, so trigger can be pressure trigger. Or change in the flow rate within the circuit and the patient is breathing, so the ventilator gives the breath. That is called as trigger. So what is trigger? Trigger is nothing but initiation of inspiration, the parameter which determines the initiation of inspiration. What is the limit? Limit is one within which the patient has to be ventilated. So if I put on volume control mode, I say the pressure limit is 30. Okay, so the ventilator will not cross 30. It will try to ventilate in volume control mode, but with the limit, pressure limit of 30, right? So that is limit. Limit does not end inspiration. You have to understand that. Now, what ends inspiration is called as cycle. Okay. So cycle is the parameter which ends the inspiration. So there can be time cycle. So I say that for 1 second from this point to this point, a flow will be delivered, and after 1 second, the flow will stop. So after 1 second, if the flow is stopping, or 0.8 second the flow is stopping, that means it's a time cycle mode or time cycle parameter. We can have volume as a cycle, that 500 ml of volume is to be given. Once the 500 ml is achieved, then the inspiration will stop. So you can have volume cycle. Similarly, pressure cycle, we can have flow cycling. So all this. So from ventilator point of view, we have 4 phases of respiration. First is inspiration, which actually the ventilator controls. So it delivers by whatever mode that we just decided, volume control, pressure control mode. With that, we give the inspiration. From inspiration, the change to expiration, that is ending the inspiration, this is called as cycle. This is cycling, cycle. Okay. Then initiation of expiration is a passive process. We don't do anything from ventilator point. We allow the patient to expire. Then beginning of inspiration and end of expiration, this is called as trigger. So we have trigger here and cycle on this side. Then we have the mode working on this side, and this is not from our, whatever is left over is expiration. Okay, so we play only with these 3 parameters. That is, this is trigger, this is mode, and this is cycle. And this is the passive thing which is happening. Now coming to another term that is called as dysynchrony. Dysynchrony is when the patient and ventilator are not matching with each other, they're fighting with each other. In anesthesia terms, we commonly call the patient is bucking. Okay, so what happens? The patient fights with the ventilator. Whatever easy ventilation was taken, that is not happening. Okay, during the expiration of the patient, we are giving breath, or during the expiration of the ventilator, the patient is trying to breathe. Both situations will be called as dysynchrony. It overall leads to the increase in work of breathing. What was the idea of putting the patient on ventilator? To reduce the work of breathing. But dysynchrony leads to increase in work of breathing. There can be spikes in airway pressure, and the reasons can be various, like improper setting of trigger or improper cycling of the ventilator. Okay, so dysynchrony, we have to understand that this patient is not synchronizing with ventilator, and we need to do something about it. Now coming to the pressures. Okay, this is a pressure graph. All of you can see the graph, or is it getting cut? This is the same graph which I had shown earlier also. So this is a diagrammatic presentation. What is happening here is the expiratory valve is closed, inspiratory valve is open. So the tidal volume is getting delivered. The pressure is increasing like this, it reaches the peak pressure. Now what is happening here? Both the valves are closed. There is no flow taking place within the tube, but within the patient's lung, during the pause phase, the air is shifting from this alveolus to that. So reshuffling of the air is taking place. This plateau you get. Okay. Then the expiratory limb opens. Now the trick here is, if suppose this expiratory valve does not open completely, so what will happen? The patient will have some positive end expiratory pressure. That is how we get PEEP, right? Not allowing the patient to expire completely. So what will be the side effect of increasing the PEEP? The side effect of increasing the PEEP will be that the carbon dioxide will be retained inside the patient. Let's come to how do we actually start a ventilator, right? So how do we start a ventilator? Like anesthesia machine, we do a pre-anesthesia checkup of the machine. We have to work on the ventilator. A complete checkup of the ventilator is to be done, right? But before that, always connect first oxygen, air to the ventilator, compressed air, or turn on the compressor. Many times we forget to turn on the compressor of the ventilator, in which or all those ventilators in which there is a compressor, right? Then after that you connect the tube, connect the power supply to the ventilator. Turn on the ventilator. Usually ventilator is turned on by a switch which is behind the ventilator. Okay, always everybody is looking for the switches in the front panel. It is usually behind the ventilator. Always try to know where the switch is beforehand, right? Before the crisis happens. So plug in the ventilator, turn on the ventilator. Connect. Third step will be to connect the tubings with which you are going to ventilate the patient. Fourth step will be to check the ventilator by attaching a test lung. Okay? Once the test lung is working nicely, then attach the patient. Don't attach the patient and then try to see, ventilator is working nicely or not. Or you say then, what is wrong with the ventilator? So first you check the ventilator and then connect the patient to the ventilator. What are the primary settings that we do on ventilator? We select a mode on ventilator, decide the tidal volume, respiratory rate, FiO2. These four things are the basic thing that we do as a primary. The secondary settings will be PEEP and IE ratio, and followed by alarm setting. Depending on mode and different strategies that you do in primary and secondary setting, you have to set the alarms accordingly. This is the most important aspect of setting a ventilator, that is alarm setting of the ventilator. Now coming to the modes, right? So basically, in basic of modes, we have pressure modes and volume modes. We will not talk about advanced modes because this lecture probably does not include that, right? So we'll be not talking about the advanced modes. We'll be talking about the basic modes. So all the modes can be divided into pressure modes and volume modes. So what is the difference between that? First, we'll understand that in pressure modes, the pressure is plateaued, right? So what we do is we deliver flows in such a way that pressure does not cross the level that we have decided. So suppose I tell the patient ventilator to ventilate the patient with pressure of 15. So this plateau will continue to remain at 15. The pressures will increase up to 15. How the pressure will increase? The flow will take place. So flow will take place and flow will increase suddenly to push the pressure suddenly up to 15. Now this angle is nothing but a ramp of the pressure control mode, ramp. So this angle we can change. We can change this by changing the flow rates. Okay. So if there is sudden increase in flow, this will suddenly rise. Then it will plateau at the desired level. It will stay there for some time, then cycle itself back to expiration, right? So this is pressure control mode. So the triggering of the pressure control mode can be anything that we have discussed. It can be time triggered or patient trigger. Patient trigger can be pressure. Patient trigger can be pressure or flow triggering. And then it will reach to that level. And at this point, it will cycle itself. Again, the cycling depends on the time, or it can depend on the flow, or it can depend on the patient's efforts also, right? Right? We'll talk about that in pressure support mode. So the pressure control mode gives a typical square pattern or rectangular, quadrangular pattern in pressure against time graph. Whereas in volume control mode, we have already studied this in much detail, so I'm not going to spend more time here. But volume control curve in the pressure against time looks something like this. Here you don't have a peak pressure or a plateau pressure. You have only one pressure. Whereas in volume control mode, you have peak pressure as well as plateau pressure. PEEP can be added in both the modes. PEEP can be added in both the modes. Okay, so there are variations of pressure control modes like pressure controlled mode. We'll talk about what is control mode. Pressure support mode, we can have CPAP, BiPAP, or SIMV pressure control. In volume control, usually we have a volume control mode and SIMV volume control mode. Okay, so this is a graph which we need to again understand in a proper way. This first graph, you can see the pressure is variable. Okay, this is a volume control mode. When the pressure is variable, it is not fixed, it becomes a volume control mode. But if you look at the flow goes up and the flow is constant. So you get a quadrangular graphics in volume control mode, right? Expiration of both the modes are almost similar. You cannot differentiate based on expiration. Ventilator has nothing to do with expiration basically. It is the leftover time, right? Now, in pressure control mode, you have a quadrangular graphic, right? You have a quadrangular, pressure is constant. Here the pressure is variable in volume control mode. Here the flow is constant, but here the flow is decremental, you can say. It suddenly increases. Why it increases? Because you want to push the pressure suddenly to the desired level. Okay. If you want to increase the slope of this curve, the flow has to change, right? You can have a squarish flow or you can have a decremental or incremental flow. Here this is decremental flow. Okay, sudden burst of flow followed by. This is more physiological. How we breathe? Initially we take a lot of flow and followed by reducing pattern of flow over the period of inspiration, right? This is physiological. So this is more pressure control mode is more physiological. It allows a better distribution of the gases within the lung. Right now, talking about control mode, what do you mean by control mode? Control mode means that the respiratory rate and everything will be controlled. The mode, the entire mode, whether volume control or pressure control, will be triggered or initiated by ventilator itself. Patient's effort will not be helped. That becomes control mode. Okay. Then we can have assist mode. What is assist mode? Now, what is the problem with control mode? Suppose I want to take more breaths. Okay, so the ventilator will not give me extra breaths. Both the inspiratory and expiratory valves will remain closed in control, right? So that is the problem. So we developed assist mode. What is assist mode? If the patient triggers in between, the ventilator will completely deliver one breath to the patient, right? That is, so most of the ventilators where you are seeing nowadays control mode, it is not actually control mode, it is assist control mode. Okay, what it is assist and control combination, right? So whenever you see a control mode, you assume that this is a assist control mode, right? Earlier, this control mode was also called as intermittent mandatory ventilation. So it was a compulsory breath which was given. No other breaths were entertained, right? So a mode was developed that is SMV, right? We'll be talking about these modes somewhere down the line. So controlled mandatory ventilation, there is all breaths are compulsory. There is no regards for patient's effort, and this leads to a lot of dysynchrony. So when the patient wants to breathe, the ventilator does not want to give the breath. When the patient wants to expire, the ventilator is pushing the air. So the timing is completely with the ventilator. Here, what you desire is the patient should be completely knocked out. Just like in anesthesia, paralyzed and sedated, then only the patient can work well on controlled mandatory ventilation. Now in assist control, what happens whenever the patient triggers, it is responded by the patient, the ventilator responded by the complete full breath by the pressure control mode or a volume control mode. Now, what does this lead to? This leads to the problem of hyperventilation. Here we have tried to show you, this is one graph in which this is controlled breath, but here you can see there are some triggers and this is assisted breath, right? Then we come to SIMV mode. I think control mode is okay, and assist is where the patient triggers and the ventilator responds with the main mode. So complete. So if you say the 500 ml of tidal volume is to be delivered, every time the patient triggers, 500 ml tidal volume will be given. That is assist control mode. Okay. So we developed something called as SMV mode. So synchronization. What happened in synchronization? We get a time window. Okay. So there is a window that we are getting. During that window, suppose I say that the patient is to be ventilated with a respiratory rate of 50. So every 4th second, one breath will be given. So we get a window now. From 3rd second to 5th second, we make a window. Okay. Now what happens during this phase? If the patient triggers during this phase, the mandatory breath is converted into assisted breath, right? A mandatory breath is converted to assisted breath and the ventilator skips the mandatory breath. So there is no hyperventilation. So this is synchronization with the patient. Okay. That is why it is called as synchronized intermittent mandatory ventilation. This can be done along with volume control mode or it can be done with pressure control mode. But soon what happened? They realized the patient was breathing in between also, and what the ventilator was doing, ventilator was not supporting those breaths. Okay, so the patient had to breathe through those tubes, long tubes, and try to pull air through those long tubes. So what the strategy was suggested? Okay, let us keep some breaths as volume control or pressure control and support the intermittent breathing with the pressure support. Some pressure support during the inspiration will give during this. So we can have now, suppose we have a SIMV pressure control mode, SIMV pressure control mode. So mandatory breaths will be different. So that is pressure control breaths. You will have to say maybe pressure control of 15 centimeter of water. I'll decide. And pressure support of 10 centimeter of water. So some breaths, the extra breaths the patient is taking, the ventilator will support only up to 10 centimeter of water. But mandatory breaths, it will give, suppose I say 15 breaths are mandatory. So 15 breaths of pressure support of 50, something like that, right? So there can be addition of pressure support, which can be done to SIMV mode. What are the basic advantages of volume control mode? The tidal volume is guaranteed, so it becomes very easy for the physician to manage such patient from home. Whatever is happening to the patient, the tidal volume will be delivered to the patient, right? It ensures the delivery. So it's more physician or staff friendly volume control mode. Whereas what is the disadvantage? The flow pattern. How's the flow pattern? It is squarish flow pattern. Whereas it is non-physiological for the patient to have a square, constant flow throughout the respiratory or inspiratory phase. Okay, so flow is fixed, whereas in normal situation the flow is always variable, right? So the variability of the flow is lost. So in this there is more dysynchrony, or the work of breathing is more and the patient is likely to get more fatigued, and this is more likely to basically be not tolerated by the patient very well. Right. So we come to pressure. What pressure control mode? What are the advantages? We have understood that there are some advantages, but there is huge amount of disadvantage. What is the disadvantage? That with the change in compliance of circuit, resistance of the lungs or chest wall, whatever is changing, the tidal volume delivered or minute ventilation delivered will go on changing because your pressure is fixed, right? And the compliance changes, so the tidal volume delivered will change. Right, that you cannot control with pressure control ventilation. So a patient needs to be better monitored in pressure control mode. So what will be the most important parameter to set on pressure control mode? It will be a low tidal volume alarm that you should be setting very well on a pressure control mode. Right. So there are distinct advantages of both the modes. Right. Coming to next mode, that is pressure support mode. It is just like pressure control mode. The squarish pattern is followed, but here the trigger is by the patient. It is not time triggered. It is triggered by the patient. So a spontaneously breathing patient will be on a pressure support mode. His inspiration will be supported by the pressure support mode. The other thing that can happen. The other thing that can happen here is you can combine this pressure support modes as discussed by SMV mode for more safety of the patient, right? We'll come to BiPAP and CPAP a little later in coming slides. So what is happening here? There are some mandatory supports and then mandatory breaths by the machine. The patient triggers. This is the assisted breath, okay? And then there is a pressure supported breath, right? So this is CME plus pressure support. I've tried to explain pressure support. It is pressure support is giving inspiratory support of pressure above PEEP. Okay, above PEEP. You have to remember that. Support above PEEP. Look at this diagram. Here, whatever support you are giving, it is above PEEP. Right? Now, what is PEEP? Now, we have been talking about PEEP so much that it reduces the interpulmonary shunt, it improves the FRC, it improves the oxygenation. Right? But at the risk of increasing the intrathoracic pressure, which impairs the venous return, which can cause barotrauma, it can increase the ICP, it can decrease the urine output, it can impair the hepatic perfusion. So all these are the side effects of PEEP, right? Applying PEEP, positive and expiratory pressure. But there are advantages as well as disadvantages. You can use PEEP mode in both pressure control and volume. So PEEP is an add-on mode. Primarily, it is not a mode in controlled ventilation or intubated patients, right? PEEP itself is not a mode. It is add-on parameter to all the modes. So inherently, if you look into this line, what I have tried to show here is during inspiration also there is PEEP going on. PEEP is not only during expiration, although the name suggests positive and expiratory pressure, but it is not like this. It is a continuous pressure within the circuit which is present at all the time. So whatever pressure control or pressure support you are applying, you will be applying above PEEP, or whatever tidal volume you are trying to deliver, you will be delivering above the PEEP level. Okay, so this is to be understood. The PEEP is not only during expiration, it is during inspiration also it is present, right? So practically, what is PEEP? PEEP is continuous positive airway pressure. That brings us to a smaller machine of ventilation, which is called a CPAP machine, which gives only PEEP, that is a continuous positive airway pressure it maintains. It has got its own applications, like in COPD patients, with patients with obstructive sleep apnea, or it can be used elsewhere also. Whereas if you want to have two levels, so one you want expiratory pressure, that is PEEP, okay, and you want the inspiratory pressure also, that becomes pressure support, and that leads to you to the BiPAP mode, okay, BiPAP mode. So if there are two positive, so bi-level positive airway pressures. Inspiration there is pressure support, expiration there is CPAP. Now these terms are very confusing, right? So I've tried to include in one graph this play of terms. If you are having a patient with invasive mode, you will have to call it PEEP. Okay, it's compulsory. For invasive mode, it has to be called PEEP. Whether the patient is on control mode or a spontaneous mode, both situations you will have to a spontaneously breathing patient or completely controlled. If it is invasive, you will have to call it PEEP. It's a play of nomenclature. Whereas in control mode, it will be called as pressure control, and in spontaneous mode, the same thing will be called as a pressure support. Patient is breathing spontaneously. The inspiratory support that you are providing will be called as pressure support. Inspiratory support they are providing will be also pressure control. Whereas in non-invasive mode, you can have control mode that will be again called as pressure control and PEEP. But non-invasive mode, when it is spontaneous, NIV, when it is spontaneous with nasal mask or oral mask, that will be called as IPAP, inspiratory positive airway pressure, and expiratory positive airway pressure, which is nothing but CPAP, right? So EPAP is nothing but CPAP. So when you are setting a ventilator, you want to put a patient on CPAP, just make the IPAP 0. Okay, so whatever settings you are making in EPAP, that will be nothing but CPAP. Okay, so NIV machine with spontaneous mode. These are the nomenclatures. It is the same thing. We have to understand that this is the same thing. Okay. So coming to the end of it. So if you want to improve the oxygenation, there are only two ways by which you can improve oxygenation of a patient on ventilator. Either play with the PEEP or FiO2. There is a relationship which is being given. This chart is very well available. We have to remember certain points in these charts, but otherwise the chart is always available online for reference. You don't need to remember the entire chart. Okay, so to improve oxygenation, either play with the PEEP or play with FiO2. Okay, to improve the ventilation, increase the minute ventilation by increasing the respiratory rate, the tidal volume, You can have with the concept of permissive hypercapnia, which I don't want to discuss. You can play around with eye ratio. You can have further other modes for the changing or ventilatory improvements. Okay. With this, when I say that pressure control, volume control have their advantage, we can have combination. I will not go in much detail about combination, but definitely whatever the other advantages, we get the advantages in PRVC, pressure regulated volume control mode. The name is a misnomer. It is not pressure regulated volume control. It is actually a pressure control mode. Okay. First breath given is a volume control mode, and subsequent breaths are pressure control mode breaths. Okay. I'll not go again. It's an advanced mode. I will not go there. Alternative methods, I have inverse ratio ventilation. No advantage of doing inverse ratio ventilation. PEEP is the only thing that you get out of inverse ratio ventilation. So we don't recommend nowadays to go for inverse. Prone positioning, definitely ProSeva trial from I think 2013 has been very clear about prone positioning benefits the oxygenation, and high frequency has limited role in adult. We don't know. COVID has opened new doors for high frequency oscillatory ventilations. The other alternative modes, I will not again go in. The adaptive support ventilation is a very promising mode which we should be looking forward. Those who are interested, it will go in the advanced level, but not in the basic level. So with this, I come to the end of, I have overshooted time. I'm very sorry. Imran, very, very sorry. Chairperson, I apologize.
It's wonderful, and you have justified each and every slide to the basics of mechanical ventilation. Getting it, this kind of talk right from the physics to the clinical implication, it's not an easy job to be covered in one single hour, though it is a topic of an entire module, and we usually take 2-3 hours for this in our mechanical ventilation workshop. I congratulate you for this. What a wonderful talk you have given. And if you know the basics very well, if you understand basics few slides well, then learning advanced mode of ventilation, it automatically comes. Since we are, yes. So thank you so much, Dr. Anant Rajput. Do we have to take questions now, or we'll take it at the end of the session? We have few questions for you in the chat box. We'll try
next speaker is waiting.
Yes. So let's take it at the end of the session. So thank you so much. And can I have a introductory slide of?
Yes, sir.
I'll stop sharing my screen.
Yes. Okay. Dr. Mohammad Saif Khan. Now our second talk is on recent updates on sepsis guidelines. Since we know that sepsis is the #1 killer, and best treatment for sepsis is prevention. Early recognition and prevention is the only thing where we can, justify being an anesthesiologist, we can justify being the clinical physician by recognizing the signs and symptoms. So now sepsis guidelines, the guidelines are basically divided into recommendations, then suggestions. So earlier, which were suggestions, it might have become a recommendation, or earlier, which were recommended, it might have become a suggestion. So let's see what we have the changes in this recent sepsis guideline, which each and everyone should know by heart, right from a primary care physician, where the patient lands up first, or in operating theater also. So to enlighten us, we have Dr. Mohammad Saif Khan from Ranchi. He has done his DM in critical care medicine from Tata Memorial Hospital, Mumbai. And presently, he is an associate professor at the Department of Critical Care Medicine, Rajendra Institute of Medical Science, Ranchi, Jharkhand. His area of expertise is critical care ultrasound, echocardiography, bronchoscopy, percutaneous tracheostomy, AKI and CRRT, HFNC, and mechanical ventilation. So we welcome you, Dr. Mohammad Saif, and we look forward to have this interesting session. You can share yours. Thank you.
Thank you, Dr. Imran. Thank you, ISA Nagpur City Branch. Thank you for kind introduction. And shall I share my slide? Can you stop sharing?
Can someone stop sharing? Yeah.
So I can
Yes. Thank you. We can see your slides.
Okay. So are you able to see and are you able to hear me well? Yes.
Yes.
Okay,
Yeah.
great. So thank you so much. And this is a long time. Uh, I mean, about of academics I have been doing since last 10 years after my MD in anesthesiology from Lady Harding Medical College, New Delhi. And I have been really grateful to all my teachers who have taught me anesthesiology and critical care as well. And because I had more interest in critical care, so I choose this line. But I have always been attached to anesthesiology, and I know that critical care and all the super specialty branches stem from. So we should not forget that ever. So today my topic is interesting because this is all we come across on daily basis, whether this is in operation theater or emergency department or in the ward, patients getting deteriorated due to the most common problem in our country, that is sepsis. Okay. So here I have come with the recent guidelines, sepsis 2021 guidelines. So these guidelines are a little bit, you can say, dry, very dry. And for those who wants quick information, I mean, you have to go through so many pages of guidelines. It's not possible. So that is why I come up with this short lecture. I'm going to cover in half an hour. And what I do is that I always start with a clinical case because I love medicine. So this is a case for you, a 65-year-old female, known diabetic and hypothyroidism and hypertension presented to emergency department with the complaints of high-grade fever with chills for last 4 days and progressive altered mental status since yesterday, that is 1 day. And she also complained of urinary incontinence and intermittent left flank pain for last 7 days to her relatives. Her vitals were as followed. Blood pressure 100/60, heart rate of 130 per minute, respiratory rate of 24 per minute, temperature of 103 degree Fahrenheit, that is high grade fever. And urinary catheterization was done, and 100 ml of light yellow colored urine was collected in the bag. And now a provisional diagnosis of sepsis was made. Now with this, we have two questions in our mind, in our cerebral cortex, that how will you define the sepsis in this patient? How will you define the septic shock according to the current consensus? Because the things, so many definitions, especially in critical care, are changing every 2 to 3 to 5 years, isn't it? So we have to know that, and how to identify sepsis. What are the dilemmas? What do we have challenges when we want to screen or detect a sepsis in a particular patient? Then how will you approach and resuscitate a case of sepsis according to current consensus of guidelines? And how will you administer antibiotics? Have anything changed in this guideline? What is the standard practice for prescribing antibiotics in sepsis and septic shock? And what are the additional therapies you would prescribe or consider for this patient? And what items, what things which are not recommended in this current sepsis guideline, which is very, very important. That's why I kept it in the last, but it's important. So first thing is that defines sepsis and septic shock. So the definition of sepsis is from the third international consensus definitions for sepsis and septic shock, sepsis 3 definition, that is known as sepsis 3 definition, which was published in JAMA in 2016. And we maintain this definition of sepsis, which is defined as life-threatening organ dysfunction secondary to a dysregulated host response to infection. We have seen this in COVID-19, right? The body's response, the host response, the immunity get dysregulated, becomes hyperinflated to the certain stimulus, to certain inciting event. And that is where there is outpouring of cytokine, and these cytokines, especially inflammatory cytokines, damage the end organs, damage various multiple organs. And that causes the situation called sepsis. So sepsis is a medical emergency. You should know that. If we just sit and watch what happens next, definitely the patient is going to die. That's why sepsis is called an emergency and we have to act fast. That is why we have to define it. So there are two terms in this definition: the life-threatening organ dysfunction and dysregulated host response. Okay, so we have to understand these two very, very importantly. So when we want to talk about the organ dysfunction, we have to take the help of few organ function scores. There are a lot of scores available in critical care medicine where we can gauge the organ functions, organ failure, we can say, or dysfunction. So far, there's such a score where we can gauge it. It is very common score, very widely used all over the world. It was established in 1996, and since last 25 years we are using. So it has established validity. So whenever you do a SOFA, which consists of 6 organs, and each organ is scored on the scale of 0 to 4. 4 is the worst, 0 is no change in the function. So if there is the cumulative score is 24. So if there is a change in score more than 2 from the baseline, or if the baseline is not available in such a patient or any patient, we can take the baseline 0. If there is an increase in 2, plus 2 in the SOFA score, we can say that patient has organ dysfunction. So this is criteria 1. Second is there should be dysregulated host response. So it should be hyperinflammation to immune of condition. How can we gauge it? Still we are thinking. We can just clinically say that this patient may have this hyperinflammatory response by looking at the CRP or looking at the clinical markers like fever, leukocytosis, tachycardia, all those things. So then we have, defined the sepsis. Now, how to define the septic shock? Septic shock is a subset of sepsis, population, which is defined as the hyperlactatemia plus need for vasopressors to maintain the MAP, that is mean arterial pressure, of more than or equal to 65 millimeter of mercury in the absence of hypovolemia. You have to rule out the hypovolemia. You have started vasopressors, plus you have high lactate more than 2 millimole per liter. That means the patient has definitely septic shock. Okay, this is the definition which we use in the current sepsis guideline 2021. So it has higher mortality. When patient has septic shock, patient has higher mortality. Now question remains, how do you define, how you have defined the sepsis, now how to identify? So for identification, we have various tools available, various screening tool available. They are quite quick and very sensitive, but not enough. Lot of tools are available. SIRS, oldest national early warning scores, modified early warning scores, QSOFA. These are the scores, and lactate is a marker, okay, which help to identify the sepsis. So if you look at the QSOFA, which was given lot of impetus, lot of popularity in the Western world that we should all use QSOFA. Everybody was happy that at least QSOFA will be able to detect the sepsis early. Okay, it was released in 2016, but if you look at the 2016 guideline, there was no mentioning of QSOFA, but still people used it in last 5 years, and they tried to do a lot of studies. So QSOFA is basically consists of 3 components: altered mental status, tachypnea, and hypotension. And each component is given 1 mark. If patient has 2 or more, then there is high risk of poor outcome. So QSOFA tells you whether this patient is going to have bad outcome or mortality. But whether this QSOFA is going to tell you about the possibility of the sepsis in the particular patient, that is still unknown. The studies have concluded that QSOFA is not sensitive to detect the sepsis. Just 60 to 70% sensitivity is there with QSOFA to detect sepsis. But if you look at the predictive mortality, the prediction for mortality, QSOFA is better actually compared to other scores like SIRS. So it's not a good screening tool, and that is why 2021 recommendations said to not to use 2 so far compared to SIRS, MUSE or MUSE as a single screen tool. So the old one, our senior intensivist anesthesiologist are very happy that still the SIRS has come back to fashion. We should use SIRS criteria to detect a sepsis in any patient. It's very simple. It takes 4 component: temperature, heart rate, respiratory rate, and WBC count, and give any 2 criteria positive or 4, then patient may have sepsis. Okay, and this 2018 comparative study between the quick SOFA and SIRS found that SIRS is better than QSOFA in terms of detection of sepsis. Then they found, this is a systematic analysis, then they found that QSOFA actually better if you want to say that a particular patient is going to die. The mortality prediction is better with the QSOFA compared to SIRS. So these 2 things you should remember. Now, this is the latest one. Probably next 5 years, we are going to have more and more research in the machine learning and artificial intelligence. So we are going to use that. And this study has highlighted the fact that machine learning, combining all the inputs from the electronic medical register, can have a better predictive value compared to SIRS, MUSE, and so far even. Okay, to predict early the possibility of sepsis so that you can start thinking of managing sepsis even before sepsis start happening in the patient. So it can actually tells you that this sepsis is going to happen in next 1 hour. So you have 1 more hour to shift the patient to appropriate facility and to start investigating. Now regarding the lactate, lactate is important. We all measure lactate. It is the one component of sepsis 1 hour bundle released in 2018. You must remember. We will discuss that. So they say that lactate should be done and remeasure, to measure and remeasure within 1 hour to see whether the first thing is that whether the patient has organ dysfunction. So lactate will tell you about the hypoperfusion first, and second, once you start the fluid resuscitation, lactate should come down as a response to your treatment, your resuscitation. So if this lactate is coming down in an hour or so, it means that you are in the right direction. And lactate also has a predictive, a prognostic value. It will tell you whether this particular patient is going to die or not. If lactate is not coming down with your standard sepsis management, then probably this patient has bad prognosis and higher mortality in the short term. So you must also remember there are other reasons for hyperlactatemia. So you should know type A, type B, and type D. Lactic acidosis, I'm not going into detail, but one important thing here, I would like to mention that you should rule out hepatic failure. You should see whether the patient is on catecholamine, vasopressor infusion. These 2 are common cause of hyperlactatemia, but there are so many you can see in this list. I'm not going to cover in this small presentation. So let's move on to the important part or heart of my presentation, and that is approach and resuscitation and administration of antibiotics. What is standard practice? So this is important slide. A patient comes with a suspected sepsis. You activate this R1 bundle. However, this also has a lot of fallacies, especially in countries where there is a lot of funds used to, in insurance, and also especially insurance patients, a lot of funding is given to treat, and that is where if you try to do everything in 1 hour, you have a lot of this spending, okay, or that is directly from the government. So that is why 1 hour probably will become 3 years in next 5 years. But so far we are maintaining 1 hour bundle. So it consists of 5 components. So lactate, blood culture, antibiotic, fluid, vasopressor. Remember like that. And what is time zero? it may be MCQ for postgraduate. What is time zero in sepsis? Time zero in sepsis when patient presents to you, or even detection of sepsis. But primarily, time of presentation is defined as time of triage in the emergency department. Okay, so this is time zero. We start from there, set the clock to 1 hour, okay, timer, and then you start the intervention. Definitely, you can save 50% of your sepsis patient from mortality. You start start measuring lactate. First, take an ABG or BBG while taking other routine investigation. Immediately draw the blood at least 20 ml from two peripheral site for the culture. Then you administer the broad empiric judicious antibiotics. Then you start administration of fluid, especially steroid, particularly balanced salt solution compared to normal saline, which are preferred in this guideline. Amount 30 ml per kg, but not to everybody 30 ml per kg. If the patient has heart condition, lung issue, or intra-abdominal hypertension, you have to think that whether I should give 30 ml per kg or should I just use point of care ultrasound to see the fluid status of the patient. Okay, so not everybody 30 ml per kg of steroid. You can tailor the approach, but always do that when patient is having lactate of more than 4 millimole per liter, and that is the situation of septic shock. Apply vasopressors early. Okay, even during the fluid administration, not later when you are completed 30 ml per kg of fluid in 1 hour. No, not like that. You have to start early so that you can minimize the requirement of fluid and maintain the mean arterial pressure of more than 65 ml. So these 5 components are there. You have to practice. And this guideline, 2021 gives the recommendation for ICU admission timing. So this patient has come to emergency department, or if you go for ICU, or what you call the call, peripheral calls to the ward. So if you find a sepsis patient, you try to admit the patient within 6 hours. If you see the patient in emergency or trauma center, you try to admit the patient within 6 hours. So that is timing given by the guideline, this guideline 2021. Now this is peculiar about the antibiotics. Okay, so you have taken the blood culture and now you want to start the antibiotic. But in previous guideline, they used to say early is better for all the patient to start administering the antibiotic immediately within 1 hour. Now in this guideline, they say they have divided, they have given a flow chart. So if the patient is having a definite or probable sepsis, okay, then you can administer antibiotic, whether patient has shock or no shock. But if the patient, if you have some doubt about the sepsis, you think that patient's condition or source is due to non-infectious reasons, okay, like acute pancreatitis or burn, or even post-operative period, you are not sure that this patient may have sepsis. What will you do in that case? Will you administer the antibiotic, broad spectrum? So now there are 2 situations here. I will use the laser point to explain. So there are 2 situations: shock is present or shock is absent in this second category. So if patient is having shock, you will administer antibiotic as you used to do previously, like within 1 hour, immediately, as soon as possible. But if there is no shock, and if you are still suspicious about the diagnosis of sepsis, then you have to wait for 3 hours. Okay, you can wait, and you can search for the causes of non-infectious SARS. If you find one, then probably should not give antibiotic. If you don't find, and if you are like sure that the patient should have a probable sepsis, then you can administer the antibiotic, okay, within 3 hours, not beyond that. So that is a little bit difficult flow chart to explain. I hope I've explained that. And another thing which this guideline tells about the antibiotic is that you should take care of the risk factors assessment. Okay, so when you are choosing the antibiotics, you should always think of whether this patient is having MRSA risk factor, whether this patient has MDR, that is multiple drug resistant risk factors. There are, you can search yourself on Google. There are very specific sets of risk factor for MDR, VRE, MRSA, invasive fungal infections. Okay, So you should know these. And when patient has any, risk factor, any 2 or 3 risk factor, then probably you can add the antibiotic for that coverage. Okay, like for MRSA, we can use vancomycin or teicoplanin along with the usual antibiotic broad spectrum. So now regarding the procalcitonin. Procalcitonin is a test which is quite costly, still not available in many places, especially peripherals. And that is why they don't recommend to use it as a, at a time of diagnosis and to start the antibiotic. So when you want to start or change the antibiotic, don't look at the procalcitonin alone. Okay, your clinical suspicion is enough. Okay, that's so important thing. You want to stop or de-escalate the antibiotic. Procalcitonin is very helpful. That is very important. But if you want to do procalcitonin for the baseline, and if you have the facility and the patient doesn't have issue with the finances, then procalcitonin will help you to track the treatment response. If procalcitonin, say, comes 100 now, and you start a treatment with antibiotic and fluid and vasopressor, and procalcitonin comes down to 50 within 1 day, it means that your antibiotics are working. So this is one way of approaching a patient with procalcitonin. This is important. The source control, very, very important. Sometimes antibiotics do not work, lactase do not come down, patients still requiring double doses of vasopressors and lot of fluids. Always think of source control. It's very, very important. So how will you identify? That's very important. So you have to do a lot of imagings, X-ray, chest X-ray, ultrasound, and you have to think about history and physical examination. You have to perform thorough physical examination, head to toe and from front to back, everywhere you have to look at so that you can find the source. And once you find a source, you have to control, you have to remove that source of sepsis. For example, lines, common source of infection. Suppose patient has PICC, old one, or patient has a central line or for TPN, for example, or a for a neutropenic patient, suppose the patient has PICC, very common cause of sepsis. You have to remove that. Or if the patient has implant, or if the patient is having some abscess cavity inside deep, you have to do advanced imaging like CT scan or even MRI to find out the septic focus. But in emergency department, it's not possible to wheel the patient to CT suite. And in that case, I think focus is very helpful. Focus is point of care ultrasound, which is coming up. And I know that all young intensivists, all young anesthesiologists are very, very thorough with the applications of ultrasound, even in remote locations. So with that, you can find most of the sources of sepsis, and you can control that with the help of your colleagues, surgical colleagues, and interventional radiologist. Now, regarding the choice of crystalloid, previous guideline suggested anyone, balanced salt or saline, anyone you can use. But in 2021 guideline, they said BSS is preferred, that is balanced salt solution like ringolactate simply or plasmalide is preferred compared to normal saline, because normal saline contains a lot of chloride. It can cause normal anion gap metabolic acidosis, a state of what you call the salt water drowning. That is a typical term used in critical care medicine when you use a lot of saline in a patient. So patient drowns himself in these salted water, and that is not a good situation because kidney tubules get affected. What about colloid? Which colloid is preferred if you want to use? So if you have resuscitated a patient with large volume of crystalloid, like more than 4 liter, 5 liter, and still patient is having, because of leaky endothelium, leaky capillaries, requirement of fluid, patient is fluid responsive with a dynamic test, which we'll discuss later, you can use colloid. But what form? Can you use gelatin? So this guidelines say no. Can you use hydroxylated starches? No, because these two are definitely harmful according to various trials. But the albumin is only colloid which can be used in this situation, and definitely, but it is very costly. You have to always weigh the cost effectiveness, cost benefit analysis. Based on that judgment, you can use that. And otherwise, it is should not be used routinely. Simple steroid is also okay, fine. What about vasopressors? So we all know that norepinephrine is recommended since last 30 years. Previously, we used to use dopamine, but I think in the last 20 years, everybody is using NORAD in the ICU. If you ask cardiologists and surgeons, whole surgeons, they still use dopamine. So if you don't have NORAD in your ICU, you can use dopamine. Its evidence is still of high quality. This is the second choice in the first line vasopressor. If you don't have even dopamine available, then you can use vasopressin, then epinephrine in the order of evidence, celepressin, angiotensin 2, which you don't have. So for us in India, NORAD, dopamine, vasopressin, epinephrine are the first line vasopressor in order of evidence which should use. But despite administration of steroid and NORAD infusion, still patient remains hypotensive. What will you do? Obviously, you have to use the second line vasopressor. So in this guideline, they suggest to use vasopressin as a first choice of second line vasopressor, because it is said, and it has been proven in the physiology, that when patient comes to you in the first 24 hours, there is a lot of vasopressin, lot of catecholamine in the patient, but that gets used up, by the body and get washed because of resuscitation. So later, after 24 hours, patient develops relative deficiency of vasopressin in the body, and then that is a time when you have to use the vasopressin. Okay, so always use vasopressin. You want to use if your patient is not responding to the first line vasopressor and a lot of fluids already given, use vasopressin early. It will save your patient from additional dialysis and renal replacement therapy. Okay, so that's one thing. And if you don't have vasopressin, then you can use epinephrine. And if you want to use another third vasopressor, third line, then you can also use epinephrine. But what about the cardiac dysfunction? Some patients may have sepsis-induced cardiomyopathy. Okay, in that case, what will you do? How will you identify that? So always keep echo with you. Ultrasound is very important whenever you come across a septic patient in your ICU. Always try to assess the patient with focus to find out the focus of infection and to look at the heart and bases, DVT screen, etc., and find out whether there is a cardiac dysfunction, which you can probably very easily do. When you start doing it, you will be comfortable and very confident. So when this patient has the signs of hypoperfusion along with cardiac dysfunction, that means that this is the time you have to start the inotrop. And among inotrops, there are choices like dobutamine, epinephrine, and the levosimendan, and then a lot of others also. But dobutamine is the first line inotrop which we should use. And if we don't have dobutamine, then probably we can use epinephrine. But then we have to stop or decrease the dose of norepinephrine, because epinephrine can act on, the beta-1 as well as alpha receptors. So back to our case. So after 4 hours of initiation of double vasopressors infusion, high dose, patient is still hypotensive. Now further fluid bolus administration is being planned. Though you have given 30 ml per kg of the steroid, you have started 12 vasopressors. Now what will you do? So what is the role of fluid responsiveness testing and dynamic fluid measures or dynamic fluid markers? So these are important. So these guidelines suggest to use the dynamic measures to guide the fluid resuscitation, like stroke volume variation, pulse pressure variation. PPV is available in all advanced multi-para monitors. If you have an arterial line, you put an arterial line and activate the PPV setup in the monitor, that will give you definitely the PPV. And if you see that PPV is very high, more than 15%, okay, and patient is on mechanical ventilation, you should suspect hypovolemia and you start giving fluid. But you should definitely don't depend on central venous pressure alone. because I don't say that CVP should not be used in such scenarios, but it should not be solely dependent on this variable CVP or any static parameter, okay, or IVC diameter for instance. So CVP and IVC diameter both are actually required. Okay, so it should not be dependent. Now, regarding the other markers to guide for this hesitation. So as I said, lactate clearance is very important. So I have already discussed about that you should measure or remeasure the lactate every 4 to 6 hours. But the recommendations are still weaker. The good thing in this guideline is that with the latest one, that they have come up with the suggestions to use the capillary refill time. So all our seniors know that what is the utility of capillary refill time. It's quite simple test to do, very quick during your rounds. You can do easily, you can do multiple times. It's very non-invasive. We should do that to guide your fluid responsiveness. And also not only capillary refill, but the temperature. So always touch the patient, see if the patient is cold, how cold peripheries are, to what level they are. So if once the periphery starts getting warm with your resuscitation, it means that your resuscitation is working. So that is also one more way, but for as per guidelines, capillary refill time is suggested to be used. Okay, so back to our case. So we have started, we are doing this. We have given a lot of fluid over 10 hours, about 5 liters of fluid, and patient is still responsive to fluid with dual vasopressors. What will you do? So will you give further fluid after 5 liters? Yes or no? So that is the common question people ask, especially residents. So there is a debate regarding the liberal fluid or the restrictive fluid. Okay, and this debate continues because in this guideline, they don't recommend anything. Okay, there is insufficient evidence to go for to say anything about the restrictive or even anything about the liberal. So the trials are underway. The Clovers and Classic trials are going on to probably put some light on this fact, that whether we should continue the resuscitation or not. But for now, I think we should continue giving fluid even beyond 5 to 6 liters on day 1. So patients' vital have now become stable on dual vasopressor and fluid. What investigation would you like to do in this case? So lot of investigation. A septic patient is a very costly patient. It requires a lot of resources and a lot of money, a lot of staff, attention. And that is why a lot of investigations. So we have to do a lot of investigation to identify sepsis, to track the progression of organ function, organ failure later, and then you have to perform the investigation to identify the focus of sepsis, imaging investigation, inflammatory markers. Then if patient has some underlying previous cardiac organ dysfunction or comorbidity, then you have to look into that also. The patient has particular organ focus, sepsis or focus, then you have to go for like CSF analysis or stool analysis or for support patient has ascites and which looks infected. You have to go for tapping, empyema, tapping, hepatic abscess, tapping, pancreatic abscess in the course of acute pancreatitis. Again, intervention radiology has to come into play. A lot of things. So that is why the role of focus is very, very crucial. You all must have to pay special attention to this. So in this patient, we did this focus study revealed collapsing IVC, normal cardiac and lung scan, no free fluid in abdomen, and it didn't reveal any significant anomaly except there was abnormal echo picture of the left kidney of inconclusive nature. So there was probably some focus of infection left kidney, probably the nephritis. And on 4th day of isostate, patient became tachypneic and drowsy. Chest X-ray showed new onset bilateral infiltration with PF ratio of 150 and PCO2 of 60, saturation 90%. CBC report showed rise in WBC, increased procalcitonin from baseline. During routine microscopy showed plenty of pus. So that is there. It is urosepsis, and there was a diagnosis of sepsis-induced ARDS made, and now we are thinking of whether to put the patient on an IV or HFNC. Both are non-invasive oxygen support. So which one will you consider according to guideline? So this patient is still conscious but having ARDS, and now we have to put the patient on either an IV or HFNC. So we have to take one call. Yes, between two. So which one will you take? So would you like to try an IV and see for 1 hour whether the patient can tolerate? Is that okay? Or you can straight away go for HFNC. If you look at the guideline, so don't get fooled by guideline, the guideline, you have to look at it. So this is a weak recommendation. They suggest to use HFNC over an IV. But this is just too weak. So use your brain and think whether patient can tolerate an IV, because an IV can give you PEEP, and PEEP is always beneficial in ARDS patient if it is used in a moderate amount. So that is the advantage of an IV, but obviously there are a lot of disadvantages. It is cumbersome for the patient to tolerate, and feeding hampered, oral hygiene hampered. So that's a lot of problem with an IV, but you can give an IV intermittently along with HFNC. That is one moderate approach, or you can say hybrid. This is the trial on which this guideline is based on. This is Florali trial conducted in 2015, and it showed that with the HFNC 90-day outcome, 90-day mortality was less, significantly less, okay, with HFNC group. And that is why they suggested, not even recommended, they suggested the HFNC over an IV. That point we should remember. Still we have to go a long way with HFNC. Now, once patient is intubated, and when once patient has the, moderate ARDS, you have to manage the patient. The ventilatory management should be according to ARDS guideline, and that is open lung approach and protective low volume ventilation with the proning. Okay, so that these three things are very important. So low volume ventilation, that is protective lung ventilation. Open lung approach, that means using the PEEP, moderate to high PEEP, and proning. Proning is level 1A indication. So you have to prone the patient for about 12 hours per day. And that is what people do not do. They do not prone their patients once they are intubated. They cite various, things that we cannot prone the patient. No. But you have to say yes. You have to be adamant and you prone the patient and see the results yourself. So it's about your approach, your own perseverance with the proning. When you have so much of evidence with proning, why don't you do it? We should do. But what about the PEEP incremental, what you call recruitment maneuver? So recruitment maneuver can be done with the CPAP, with the pressure control, and with the PEEP. So with the PEEP, you do incremental PEEP strategy. That is, you have to increase the PEEP to certain level and see the saturation is increasing or not. But that is actually in this guideline not recommended. They recommend against an incremental PEEP strategy. This is the important point you should remember, that do not do that. PEEP may cause barotrauma and PEEP may cause hypotension. Don't use this high PEEP strategy, incremental recruitment PEEP strategy. Now we come back to our question. So this is the fifth one which we want to address in this. What additional therapies? So in a septic patient is always a very general critical care patient in which we have to take care of general principles of critical care. So you should remember the fast hug, obviously. So if you talk about guidelines, so we have to stick to our presentation on guidelines alone. So don't go for fast hug BID. So we just look at the evidence. So what they say about vitamin C. So everybody was using vitamin C since last 5 to 7 years. A lot of trials came with vitamin C, but they were synthesized, the trial findings and patients analysis, and meta-analysis performed, and they all suggested not to use vitamin C. And in this guideline, they maintain not to use the vitamin C. Okay. But regarding steroid, the recommendations are better today in this guideline compared to the previous one. In previous one, they were not sure about using hydrocortisone, so they suggest against using it. But in this guideline, they say no, you should use it when patient is having septic shock and ongoing requirement of vasopressor, ongoing requirement of NORAD. In that case, you should use IV steroid early. Which steroid? They say hydrocortisone is okay. 200 mg per day. You can use as a continuous infusion or intermittent boluses of 50 milligram every 6 hourly. The quality of evidence is moderate, that is better than the form. This is Orange's trial done in last, I think, 3 years back, published in JAMA. And this trial was about the hydrocortisone, vitamin C, and thiamine, HAT therapy, HAT, hydrocortisone, uh, 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 therapy, and thiamine therapy, and steroid. Okay. So these three, and vitamin ascorbic, A for ascorbic acid. So I forgot, I'm so sorry about that. So A for ascorbic, that is vitamin C. So HAT therapy, that was Marek's protocol, which was actually released in 2017 by Marek. And this Orange's trial is about that. So they showed that when this HAT therapy used in the septic shock patient, actually it reduced the time to the resolution of shock. So suppose shock resolved in 2 days. So this HAT therapy actually shortened the time of shock, total shock, and it actually resolved earlier with the HAT therapy. But this Orange's trial is not a part of this guideline. I have just mentioned it. Probably in this next guideline, we might see the evidence, more evidence in this. Now regarding the ulcer and thrombus. So everybody knows you have to give the peptic ulcer prophylaxis, stress ulcer prophylaxis, and also we have to give the DVT prophylaxis. So they say they maintain that we should use definitely the Clexane and pantoprazole, but they suggest against using mechanical prophylaxis or DVT prophylaxis, that is your pump, your sequential compression devices. Okay, so DVT pump in addition to pharmacological prophylaxis over the pharmacological prophylaxis alone are not advised. So don't use both. Use just one, that is pharmacological prophylaxis alone, or either you use the mechanical prophylaxis. The patient is having some contraindication to pharmacological prophylaxis, that is Clexane. But don't use both, because both are equal to single intervention. Regarding the renal replacement therapy, they say yes, we should, when there is a definite indication to use the renal replacement therapy, that is dialysis or CRRT, should do. But if there is no definite indication, do not simply chase the urea and creatinine, or just one criteria, that is urine output. You have to see the patient overall metabolic acidosis, hyperkalemia, ECG changes and all to decide upon the need of RRT. Regarding glucose, they maintain the same recommendation. They say yes, we should maintain the glucose below 180 milligram per deciliter. They recommend insulin therapy if it is going beyond that. And regarding the bicarb, they are against. They say no, we should not use to improve the hemodynamics or reduce the vasopressor requirement, because this recommendation is based on the bicarb ICU trial. Okay, this was multi-centric trial, and it showed there was no difference. There was no benefit of using bicarb in such situations of shock or vasopressors requirement. And regarding the acute kidney injury, yes, they suggest to use sodium bicarbonate if patient is having metabolic acidosis, that is pH less than 7.2. Okay, what about ARDS? So everybody might question that what we should do in ARDS, metabolic acidosis. Sorry, just acidosis, because we gave low tidal volume and patient developed hypercapnic respiratory acidosis. So what we should do? Should we give bicarb? So in this guideline, they have not mentioned that. But if you look at the ARTNEST trial, they say yes, we should give. But in this trial, in this guideline, they don't talk about giving bicarb in ARDS situation of hypercapnic, permissible hypercapnic situation. What about enteral feeding? They say yes, we should start early, within every 2 hours of septic shock recognition. So, but obviously we know that when patient is having the requirement of dual vasopressor, intractable shock, definitely we should hold the enteral feeding. And what about TPN? So this guideline do not talk about TPN. I don't know why, but they have not suggested anything about TPN. So we have to take the help of other guidelines like ESPN or ESPN. And What about setting goals of care? So these are peculiar things about this guideline. In previous 2016 guideline, there was less emphasis on setting the goals of care, but in this guideline, they recommend to discuss the goal of care and prognosis with the patient and family. So in our country, it's very important that we daily prognosticate the patient. We should talk with the patient's relative every day, at least twice a day. We are given the situations. So that depends on situation, obviously, but that's very important part of our ICU care. And we should address the goals of care early rather than late, and so on, so many things. So I'm just, but what about the palliative care? To the suggest against the routine formal palliative care consultation. So this is something which is new to many of you regarding palliative care consult. So there is a specialist called palliative care who has degree with MD in palliative care medicine. So many hospitals do not have that, obviously. So that is why they suggest against using that. So you can yourself do the palliative care planning and also the discussions with the family if patient has terminal disease. Okay. Now, what about the sepsis education? This is something which is again new in this guideline. They talk about the written or verbal sepsis education, or regarding the diagnosis, treatment, post-ICU care syndrome or post-sepsis syndrome, or in COVID era, you can say post-COVID syndrome or long COVID syndrome. All those things, if you have written pamphlet or something handout, you should keep outside your ICU, or you can show on your television, which is just outside ICU, and probably that will help a lot to the patient's family to decrease their anxiety regarding what is happening with their patients inside ICU. Now regarding ICU handover, they suggest, this is something which is again new in this guideline. They say we should use the handoff process of all the ICU patients in which the important information and transitions of care is retained properly. So this is what we do as an anesthesiologist. If you shift the patient from anesthesia to intensive care unit, always give a proper handover, written one. If you can have a written one, that is the best. Okay, in the form of register or in the form of printed handover handouts to the ICU fellow. And if the ICU fellow is shifting the patient to some other ward or something, that also can be done. That's very important. Then again, in this guideline regarding ICU follow-up, they have recommended to discharge the patient and always follow up the patient. So you can actually run your own OPD, post-discharge ICU follow-up OPD, and in that you can see how your patients are doing. And in that way, you can help a lot, because critical illness has a long-term sequelae on patients' physical, mental, social, and psychological, dimension. So you have to look into those things. So they say, yes, you have to do that. And if you want to refer to the rehabilitation center or unit or in your city, or you can do, you have to do that within 48 hours to 72 hours ICU stay. That's also one more thing. If you are not able to, you cannot cure the patient, always rehabilitate at least. Now, the last one is what are items not recommended in the current sepsis guideline bundle. So these are the things we should not do. Don't use QSOFA as a single sepsis screening tool. Do not use just add MRS, anti-MRSA, antifungal, or dual gram-negative coverage, or combination therapy in the absence of risk factor. Do not use starches and gelatin for fluid resuscitation. Do not use levosimendan for the cardiac dysfunction. Use dobutamine rather. Do not use incremental P titration. There is no point of doing the polymyxin B hemoperfusion. Okay, that is not what we do at a daily basis here in our country. Every few center we are doing, but in this guideline they suggest not to use that. And do not use the immunoglobulin in sepsis and septic shock. And do not dialyze the patient without a proper indication. No vitamin C should be used, and sodium bicarbonate also, to improve the hemodynamics or decrease the need of vasopressors in septic shock induced lactic acidosis. So take home message. So always keep yourself updated with sepsis guideline. Use focus, use capillary refill time, use your clinical mind to detect a patient. Be very careful to start the wide spectrum empiric antibiotics at the onset of sepsis, but always de-escalate. To that I have not mentioned in this of my presentation that what about this de-escalation strategy. So always use procalcitonin, de-escalate early if you have started a wider spectrum of combination therapy. That is important to curb the menace of antibiotic resistance, and always use the sepsis education and first and then let others know what is important and crucial about the sepsis, and use the handover checklist. So that's all for today. Thank you so much for your attention. This is my YouTube channel. So I have come up with so many videos. There are 2 YouTube channels of mine, so 51 videos in first one and another one. So I've started this last two years back and successfully running for all of you. So let me know your topics so I can make. And this is just important announcement of my, our academic feast, which we are going to conduct in Ranchi. It is a beautiful place. All of you are welcome to come. This is the link QR code for registration. So we have 4 workshops, important workshops on ultrasound and on airway and on mechanical ventilation, dialysis and all. And then we have 2 days ICCL conference. Thank you so much again. Thank you, ISA Nagpur City Branch office bearers, to give me opportunity to speak in this forum. Madam Dr. Kiran and Dr. Ajit, Dr. Imran, and Madam Hude ma'am. So everybody and all my audience, thank you so much.
Thank you, Dr. Saif. It's really, really wonderful. Like, you could be able to tell us the guideline, keeping it in sync with the clinical scenario. I think this is the best way to teach, and best way you said is like, although there are recommendations, there are suggestions, but ultimately every case is different, and we have to use our clinical acumen. We have to use your brain also at the time of making any decision for the best outcome of septic patients. So I congratulate you for one of the best presentations we have seen on the guidelines. Thank you so much. And I think the forum is open for the questions, if we have any. Can we take up the questions now?
Yeah.
We have a few questions.
Few questions,
for both speakers.
Yeah. So, Dr.
Anant, there is one question for you. For elective postoperative ventilation, is PCV recommended?
Yeah, we can use it, but as I was discussing in the end, that PRVC I would prefer over PCV. If you have a very good ICU setup, then definitely PCV mode is going to be better. Okay, in post-operative situation.
But
then the vigilance is very important during that cost.
This extended question is, in which patient should we use a volume control mode over the post-operative ventilation? For the post-operative ventilation.
As I was saying, that it's slightly non-physiological compared to pressure control mode. To use volume control mode is slightly non-physiological, but definitely when you want to have precise ventilation as far as lung recruitment is concerned, like if the patient has undergone lung surgery and now you want to properly recruit the lung, so that time you can go for volume control mode. But otherwise, there is no distinct advantage of using volume control mode. All ARDS patients, everything you can manage on pressure control mode, provided you have that kind of staff who's equipped enough to recognize when the pressure control mode is giving you trouble, right? And the best option right now, I would still feel that it will be PRVC to go for in post-operative as well as other scenarios.
Thank you.
That is dual modes.
There's one question from Dr. Ravi Nikade. Is there any difference between PSV and PSV Pro?
Pressure support, ventilation
and PSV Pro mode.
Actually, see, pressure support mode means supporting the inspiratory phase, right? And PSV Pro is when we are again automating that with the software based. Okay. So the point is, if you are doing it manually, then there is no point in going for PSV Pro. But when you are feeling that, right, you lack the clinical support system, so then you can go for PSP Pro also, right? But I don't see a major advantage in all the even adaptive support ventilation to that extent, because adaptive support includes all the modes and everything. But I don't see a major advantage, and I have not felt the requirement to go for very high profile modes, because if your staff and teaching candidates are adjusted to it once for doing some kind of study, or these newer modes are quite good, but otherwise these basic modes do the job. You have to understand between the difference between volume control mode, pressure control mode, pressure support. uh, uh, you can use SIMV. There has been one question from Jitesh. Is there any scope of SIMV? Scope, I would say the SIMV mode is preferred mode by surgeons, where they would not like to look into the patient and they will put the patient on SIMV mode. When we are into the business where we are doing distinct monitoring and adjusting ourselves and our fine-tuning the patient, I don't see the need of all this kind of fancy modes. We can still do very well with the basic modes. The dual mode definitely has an advantage. That much I can say.
Any other questions? Any questions from audience?
I think, shall I say something about PSP Pro?
Yeah.
Yeah. Yes. So somebody asked about PSP Pro. See, all these Pro things are fancy, add-ons. So so now you know what the intensivist and even anesthesiologist and all the emergency physicians they want to keep themselves free of any much of maneuvering the ventilator, and they want to keep themselves a little bit comfortable when the patient ventilator is going on. So this Pro thing is in PSV, I think, is just switching on, automatic switching on the controlled what do you call apnea backup. So apnea backup is already when it will sense that whether the patient is able to initiate the breath or not. If this patient is going to apnea, it will automatically turn on. That is PSP Pro, and which we see normally by default in any ventilator. So just PSP Pro is just some kind of some brand of ventilator where they have called PSP Pro, but I think in all PSV, all CPAP, we have that by default, isn't it? So that's the answer, I think.
Yeah, very true, sir. Questions from audience? Yeah.
From sepsis, I think there should be a lot of questions. I was expecting a lot of questions from the audience because sepsis is something which everybody wants to know and is interested also. So I don't know why nobody has asked question.
I have a question, Dr.
Yes,
Saif. Sometimes people wait for a central line to be put so that to start the vasopressor. So what are the recent recommendations for that? How much of the strength we can give through peripheral, or should we right away start peripheral line and start early or adrenaline?
Yes, sir. So for this thing, actually, I actually skipped this because in this guideline they said about peripheral line, using peripheral line to start the vasopressor, because to putting a central line is sometimes difficult. Sometimes it's not possible to put in a short time because of logistic issue, and peripheral line is easy. So if you are giving a lot of fluid and you want to start the vasopressors early within 1 hour, you can start through peripheral line. Now, regarding the dose, always start a low dose. And obviously, when you are giving a vasopressors through a peripheral line, don't give fluid through that, or don't give any other. Obviously, this is a fact, and this is a common sense that don't use anything apart from vasopressor line. I mean, that has to be dedicated line. So this is one important thing, and you should use the bigger vein, and you can use the low dose vasopressor with the big IV fluid. I mean, 500 ml fluid, and put some 1 or 2 vial like that. You can use, not a concentrated one, and definitely central line as soon as possible. You should try to put, and then switch the peripheral line vasopressor to the central.
Thank you.
But regarding those, there is no cutoff, sir. There is no cutoff given.
Thank you. Thank you.
Yeah. Can I say something?
Yes, yes.
Yes.
Go ahead.
So the idea is it should be used as a bridge. Okay. So don't delay vasopressors by saying that I am putting a central line after 1 hour and that's why I'm going to start vasopressor after 1 hour. So start, even if you start with peripheral line, that is okay. But as soon as possible, you should try to switch over to central line. There are other issues besides the scientific data, that limb positioning problems, the BP cuff application on the same side, those issues, and sometimes extravasation. So a non-reliable infusion dose goes. There is no hemodynamic wise, you can't say that peripheral line will have lesser effect and central line will have better effect. No, it's not like that. Just because there is more chance with the time going on, the more chance of cannular displacement to the position related issues. The patient changes the position or somebody gives a lateral position to the patient. So same infusion will not continue. The rate of infusion will fluctuate in the peripheral line, which is unlikely to happen in central line. That is the only idea. And the recommendation says that you have to start even with peripheral. That is not a problem.
And how about the arterial line? Like any?
Yes.
Yes.
So for arterial line, they have recommended this time. In 2014, hemodynamic guideline was published by the European Society of Intensive Care Medicine, in which they said clearly regarding the use of arterial line for any patient who has septic shock or requiring vasopressor. Okay, so arterial line are must actually for any patient who is in septic shock. For one for monitoring and another one for the responsiveness testing, PPV and all. So that is, yes, you can actually look at the waveform and analyze yourself that whether patient is responding to fluid or needs more fluid.
So I feel that don't use arterial line for just the values, right? It is very important to use them for with the waveform, the size, the width of the waveform, the narrowing, the peaking. All those things have to be seen when you're putting. And please also try to correlate where the site you're using. Right? That also depends. Femoral site versus radial site. So that is also important when you're putting arterial lines. So correlate those waveforms and values with those sites also.
Yeah, I think when the patient is requiring very high dose vasopressor or sometimes triple vasopressor therapy, that the radial artery is going to dampen. Definitely is going to dampen. In that case, femoral is better. So we then switch to femoral always when patient is going to kind of irreversible type of shock or very high vasopressor requiring shock.
And vasodilated shock, sometimes it is easy to put arterial line, the radial line in vasodilated shock. But then later, once the patient becomes vasoconstricted, it becomes very difficult to put any kind of line, and the USG guidance is sort of a must. I would say that you under vision, you should put the arterial line so that you avoid injuring the posterior wall and thereby inciting a thrombus, because already a septic patient is thrombotic patient. So more injury to the posterior wall of the artery, more chances of causing thrombosis of the artery line, especially
Saif, they have given more emphasis to capillary refill this time in this new guideline.
Yes.
So don't you think that it has also its own again fallacies and false negativity in the case of intense vasodilatation also, or in the case of vasoconstricted shock also? So what is your take on that?
So definitely there are, but in the resource, so this guideline is very unique about the taking the considerations of the resource constraint setting, resource limited countries. So they have, these guidelines are not just for the rich countries, even for poor countries, and that is why they have included CRT. It's not like following the standards. It's also about taking the consideration of cost and resources. So in that way, I think CRT is good. Capillary refill time is good, but obviously it is not the best.
Thank
you.
Thank you. I think no questions.
I think now we can close the session. Now I would like to hand over the part to MOC, Dr. Ajit.
Thank you, sir. Now I request Dr. Sarita Jogodekar ma'am Honorable Secretary, ISA Nagpur City Branch, for a few words.
Yeah, before that, I would like to thank both the faculties and chairperson. It was an excellent deliberation, and there was a brushing up of our knowledge also, and plus there were so many additions. So thank you so much.
Thank you, sir.
After excellent.
Thank you, Team ISA. I would like to thank Vare Madam, Bhure Madam, and even Ketki Madam, because she had been giving so many calls and all updates very properly. Thank you, Dr. Joglekar. Thank you.
Thank you. I took this opportunity to thank Vice President ISA National and Head of the Department of NKPSIMS, Dr. Anjali Bhure Madam, for guiding us for arranging the CME on the critical care updates. My sincere thanks for the GC member of MSc ISA, Dr. Saurabh and Dr. Sheetal, for joining this program. Sincere thanks to the faculties for today's CME. I know physics, chemistry, and mathematics is to be used in the biology is an art, which is only used by the anesthetist. And the basics of ventilation is a perfect example of this. Thank you, Dr. Anand, for having widely covered this, and in a very precise manner you have covered this. Thank you so much. Clinical questions we posed while dealing with the patient in sepsis in a stepwise manner and the guidelines that has been given by Dr. Saif today, and a total approach from receiving the patient to the complete handover, rather I would say the follow-up and rehab is very, very nicely covered, sir. Thank you so much for gracing today's program as a faculty. I would like to also convey my sincere thanks to Dr. Imran, a consultant critical care and anesthesiologist at Asian Care Center, and joining us today for the program. Again, my thanks to Dr. Ketki for, as Dr. Ananta said, she has coordinated with everyone. So thanks, Dr. Ketki, for coordinating. Dr. Ajit, MOC for today's program, working as assistant professor with NKPSIMS for nicely conducted the program. All the senior members who have joined from ICNCB, Dr. Shubda Deshmukh Madam, Dr. Savargaonkar Madam, Dr. Charuta Gadkari Madam, and Dr. Vaishali Shilgaonkar for joining program today. My special thanks to Dr. Naresh Paliwal, sir. Naresh Paliwal, sir, is currently the president from Amravati ISA. Thank you so much, sir, for taking out the time and joining the program. All delegates and all the members of ISNCB who have today joined, my sincere thanks to them. Special thanks to Nishan from Elantech for making this program on YouTube Live. And I think excellent coverage of the topic. And if the time permits, today again, in the coming days, we have a number of topics in the critical care which we needs to be covered, like the arterial lines and invasive lines and updates. Hopefully we can meet again. Thank you for joining us today. And I think we'll take a leave. Thanks.
Thank you so much, everyone.
Thank you. Thank you so much. Bye-bye.